Sanjay Sogani, sir. Thank you very much. I now invite our first speaker for the day, Dr. Shidhu Singh. She'll be speaking on how to approach pneumonia. I invite ma'am to the stage.
का है आज टाइमर 14 So a very good morning to all of you. So I will straight away go to my topic, that is how to approach pneumonia. I think every one of us has encountered patients of pneumonia, and especially during the COVID we had a lot of viral pneumonias coming in. So let us see how to go about. The pneumonia can be actually divided into these subtypes, and these can help you to identify what type of pneumonia is there and get the specific investigations and the specific treatment done. So one is the alveolar pattern, in which the alveoli get filled with pus. The second is the lobar pneumonia, with the lobar, so it confines to one particular lobe of the lung. Bronchopneumonia has a more patchy distribution. Then you have the interstitial pneumonia, in which the interstitium is involved, and then there are certain atypical pneumonias. So what are the typical history? Previously healthy patients with sudden onset of fever and shortness of breath. The signs include fever, tachycardia, tachypnea, a productive cough, pallor, cyanosis. On examination, as we teach the residents, there is dullness to percussion, decreased breath sounds, and I actually wanted to help you. Is there an audio from this? Audio aa jayega? Chalo, so let's listen to some crackles. ऑडियो दिया हुआ है, आप दीजिए, तब तक मैं आगे का बता देती हूँ एक बार. So chest X-ray shows lobar consolidation, CBC shows leukocytosis, and sputum sample contains neutrophils, RBCs, gram stain, and that may be positive depending on the organism. So I think we have the audio with us now, no? So in ILD, you have the typical end inspiratory crepitations, and this you can get biphasic. Now let's listen to some rhonchi. And a typical pneumonia may have some egophony also, which may be like an E sound, eh. Or it may be something like a sound, The X-ray will have some lobar pattern here, so you can get all of these findings in a patient with pneumonia. So bacterial pneumonia, as I just mentioned, mostly community acquired pneumonias are bacterial. The most common organism is Streptococcus pneumoniae. The risk factors that predispose to pneumonia are chronic diseases such as COPD, heart failure, diabetes, immunosuppressed states, and particularly in patients with splenectomy, and that's why we immunize them with pneumococcal vaccines. Lobar will be restricting to one lobe. And now who's going to tell me which sign is this on the CT scan? Yeah, loudly. Okay, so good. So it's an air bronchogram sign. What happens is all the alveoli are filled with pus, and you can see the air that is there in the branching bronchi which will appear like trees. So this is the classical air bronchogram sign, which means that the bronchus is patent, and this is a consolidation with a patent bronchus, and most likely it is a pneumonia. So prior to the antibiotic era, we had 4 stages of pneumonia, which included congestion, red hepatization, grey hepatization, and resolution. Bronchopneumonia, as you can see in this particular patient, it is precipitated by inhalation of a causative organism. There is a peribronchial inflammation which can spread through pores of corn, and these consolidation are patchy. Many times they may coalesce together to form a bigger pneumonia, which can present like a lobar, but the classical differentiation is it is patchy and in multiple lobes. So this X-ray here you see patchy infiltrates. If you look carefully at the CT scan, other than these patchy consolidation, what do you see? What is of significance to us? Can you please come in front? I think we can have better interaction. There are few people, I think. Please come in front. We can have active participation from all of you. So what is there here in this particular patient? I'm giving you a clue. See, what is it? क्या है साथ में निमोनिया के? एक ये लाइन है ना, ये क्या है लाइन? सेप्टा में क्या है? Effusion. So this is very important. If you have an effusion with a pneumonia, always drain it. Parapneumonic हो सकता है, and if you don't drain it, the resolution of the pneumonia will be very slow. And it may be pus also. If you drain it and you find that the pH is less than 7.2, you have to put a tube also sometimes. So this has a prognostic and treatment associated significance. So please don't miss it. Treatment of community acquired pneumonia is ceftriaxone or amoxiclav with a macrolide, which may be azithro or clarithrol. In the Western guidelines, they have mentioned fluoroquinolone. But why don't we want to give fluoroquinolones? Yes, so in our country, we don't know what is actually going to turn up as tuberculosis. So always be very, very careful. The take-home message from my talk is don't give fluoroquinolone. Prefer to give either of these. So this gives you a good cover for the atypicals, which are, some seasons you get a lot of atypical pneumonias too. So let's see the outcomes of a community acquired pneumonia. One would be complete resolution from presentation till 5 weeks. So this was one of the questions that we always asked our residents, how much time does it take for a radiological resolution? So around 4 weeks of time generally required, but you don't need to chase this. You need to chase the examination findings like the saturation, the symptoms. So you may have this, but the patient is asymptomatic. You don't really need to treat. This was if everything went good, but suppose things didn't go good. What are the complications? One is a pulmonary abscess. This particularly happens in patients who are immunosuppressed, those who are alcoholic. What you see is necrotizing cavities, and here you can see the cavities along with bilateral effusions. So you need to drain these as well. The second complication that we expect is the pleural that I have mentioned. This is a patient currently actually admitted with us. So parapneumonic effusions are notorious for having fibrinous inflammatory reactions to the adjacent pulmonary inflammation. Empyema is associated with purulent fibrinous inflammatory reaction due to the infectious spread. So this particular patient had this pneumonia on day 1. You see some reticulations, bilateral basal. She recently had a laparoscopic surgery, and after day 7 she developed this. So we started her on antibiotics here. Despite that, what you see here, what is there? The blunting of the CP angle. So as soon as it comes, you suspect fluid, send the patient for an ultrasound. If there is fluid, get it drained. So this is the dictum. Actually, the sun should not set down on an empyema. It should always be drained. The other complications that we expect are disseminated infections, bacteriemia, and multi-organ failure. Coming to the case, 15-year-old girl with fever, cough, couple of episodes of violent cough, started having shortness of breath for the last one day. So patient was seen somewhere at the local level, and she was diagnosed as a lower respiratory tract infection and given amoxiclav 625 BD. So is this the right dose? ठीक है, चलो, I'll come to that in a short while. So this patient, after 5 days of illness, came to us. Her pulse was 120, respiratory rate 35, temperature 100, urea 34. This was the blood pressure and saturation was 95. How many of you will admit the patient? Okay, so 2 people and rest will give home therapy. Send her home. So we have some guidelines, and there's this curve 65 index which can actually help us to decide where to send the patient. So let's see. Confusion is given as 1. So patient is talking well, so there's no confusion. Urea more than 20. So you have a urea of 34. It will be 1 score. Look at the respiratory rate more than 30. Another 1. BP systolic less than 90 and diastolic less than 60. Another 1 score. Age more than 65. So you how many score did this girl get? Louder. क्या क्या हुआ देखो, यूरिया मोर देन 20 हो गया, रेस्पिरेटरी रेट मोर देन 30 हो गई, और डायस्टोलिक ब्लड प्रेशर लेस देन 63. So you have to admit her. If you get 1 score, you can treat the patient in the OPD. 2 means ward, 3 means ICU. She actually needs ICU admission. So you have to be careful. ये score आप याद कर लीजिए, चाहे इसका photo ले लीजिए. So this is 1 score that will help you to decide the treatment for your patient with pneumonia. So आप coming back to a particular patient, उसको admit किया. We also got a CT scan done. So what you see here is a patchy pneumonia. Now this is a brownie point question. Who's going to tell me what else is there is on the CT scan other than, pneumonia? Come on, one of the residents. You can't miss this. What is this? Patient had a bout of violent cough. ये क्या है? ब्लैक मतलब सीटी स्कैन में क्या होता है? ब्लैक इज एयर. सो इज द एयर इन द mediastinum normal? No. What is it then? Air in the mediastinum, I think someone said it there, pneumomediastinum. So many times our patients with pneumonia, when they cough violently, they can have a small tear somewhere, and this air can leak along the hilum vessel to the mediastinum, and this is called as pneumomediastinum. So coming to the treatment of the patient. Now we have got the best antibiotics available. You name it, you can get the best antibiotic, and you have so many people telling you give this antibiotic, this is better, the other antibiotic is better. But how do we give our antibiotics? Without any rationale. So we have a very beautiful car that is of antibiotics which are excellent. But the wheels of this car unfortunately are of a cart which is based on the culture facility. On what protocols are we actually giving our patient these very good antibiotics? Do we have a justification for this? Unfortunately, this is leading to so much of resistance. We are blindly giving antibiotics without any rationale. So we have an excellent car with very poor culture facility. In coming back to our patient, in our particular case, we actually got 2 things done. We sent the pneumoslide, and the streptococcus pneumoniae in this case was negative, but the legionella came out to be positive. So this was a case of legionella pneumonia, and the best drug of choice for a legionella is, who's going to tell me? Anyone? So legionella is atypical. So drug of choice क्या होगा? I already told you in the first slide. Macrolides, wonderful. So The Legionella, indirect immunofluorescence was positive for Legionella pneumonia. And I will come to it in a short while, how we will treat her. So let's choose one. What characterizes Legionella pneumonia? Intense cough due to severe tracheobronchial inflammation, dehydration impairing the mucociliary clearance, recurrence of pneumonia at the same place, air space type of pneumonia, interstitial pneumonia, water and soil source. How many for A? B? C? D? E? F? No one for anything. Come on. A? Okay. So let's see. The answers to this are: intense cough is very characteristic of mycoplasma. Dehydration impairs mucociliary clearance in all pneumonias. Recurrence of pneumonia at same place, there's some structural abnormality. Either there is a mucus plugging, or there is a growth, or there is a foreign body. Or it can be a bronchiectasis or some congenital abnormality. Air space type of pneumonia is seen in pneumococcal. Our patient was negative. Interstitial pneumonia in mycoplasma. And come on, this was a PG question. I expected at least one of the PGs to answer it. Water soil sources for Legionella. So classically, suppose आपका कूलर का पानी में Legionella आ गया है, तो it will spread through aerosol and all the people at home will get infected. Okay, so it is very classical. So what to start on day 1 of hospitalization? Antibiotics, cough suppression definitely, because you don't want that pneumomediastinum to increase. Oxygen therapy not needed, saturation 95. Monitor closely to get clinical stability. The drug of choice here is, as Dr. Raj Gupta just mentioned, injection azithromycin IV infusion. The one thing about azithromycin injection is it is very painful. So suppose your patient is taking good oral intake, you can switch to oral also. Cough suppression done. So the bottom line is that right key for the right lock is necessary, otherwise you can't open the lock. So always identify what type of pneumonia and then treat. So another quick, I already mentioned this particular patient here yesterday. I think 1 or 2 more slides. Cough, fevers in 7 days, breathlessness is 1 day. And since if you look at the X-ray, bilateral patchy infiltrate, you see a ground glass peribronchovascular subpleural, you immediately identify it as a atypical pneumonia or a viral pneumonia. So we sent the H1N1 swab which was positive, and we started the patient on Tamiflu. This patient was initially on high flow, then switched to HFNC. Patient responded and we discharged this patient yesterday. So important to, so I think this one thing I really wanted to highlight is the point about giving amoxiclav at 625 mg BD. So if you suppose have a snake in the house, what will you do? Will you injure it or will you kill it? How many for injuring it? So I think everyone wants to kill it. And a injured snake is actually more dangerous. So if you have a bug in the body, if you give the dose at suboptimal, suppose azithromycin 250 mg will only injure it. You give it only for 3 days, it will injure it. You stop when you feel better, is meaning that you are creating more resistant strains. So injuring leads to immediate cure, and it is often self-treatment by the patient, but you need to kill the germs, give it in proper doses for the proper duration of time. So I think my take-home message is future is for specific therapy, personalized therapy, etiological diagnosis of infection, cut down misuse of antibiotics. Let us hope to have a high positive predictive value of these tests to use them in OPD. Thank you. Any questions? Mic is not working.
What is the exact dosing?
So amoxiclav has to be given 8th hourly always. Never BD, because that creates resistance, and the trough levels are achieved only like if you give at 8th hourly, the adequate amount of trough levels. So it has to be given 8th hourly.
Thank you, Dr. Shitu. Nicely covered the lecture. I want to ask one thing from Dr. Shitu. Nowadays, few patients are coming with bilateral pneumonia presentation, but COVID is negative and swine flu is positive. One patient I have seen, swine flu positive, typical presentation COVID 8, CTSI score was 8, and D-dimer was 8,000. So what is your opinion? What was the treatment?
I think that's a wonderful question, and all of us sitting here are encountering nowadays swine flu that is more prevalent than COVID. So you will be having these waves. Sometimes it's COVID, sometimes it's viral. Some virus keeps on going. It may be H1N1 at this point. It is very difficult to differentiate it radiologically between swine flu pneumonia and a viral pneumonia. You need to get your patient tested. Getting both the tests done at the outset, may be a problem to the pocket of the patient. So you can sequentially get it done. Either get a COVID done prior, and second step you can get H1N1. Especially if if the patient has had COVID in the recent past 2-3 months, you only get H1N1 then.
Any role of LMWH if D-dimer is 8,000 and swine flu positive, COVID negative?
Yeah, so we do chase the D-dimers. We have to treat that, and especially rule out DVT and pulmonary embolism. Concomitant pneumonia may be due to an immunosuppression due to bedridden state, and that may be a comorbid pneumonia with a PE or a DVT.
In every viral pneumonia, there is a hypercoagulability is there. So should we go for DVT prophylaxis also? DVT, I think chemo prophylaxis or pump prophylaxis. Can we go for both? Thank you, Seetu. Excellently talk about the pneumonia, every aspect. Next speaker is Dr. Prerna Singh. She will be talk on coronary CT angiogram, indication and the role of preventive cardiology.
Dr. Prerna Singh Saharan is consultant radiodiagnosis at Rajasthan Hospital. She's a young and enthusiastic radiologist with experience in ultrasonography and cross-sectional imaging. She has particular interest in cardiac imaging. She has attended various national conferences. I now invite Dr. Prerna to the stage.
Good morning, everyone. I'm Dr. Prerna. I'll be speaking on coronary CT angiogram, indications and role in preventive cardiology. Thank you, first of all, for inviting me here to speak on this topic. Basically, my topic I'll be easy to explain by this slide, how to stop a heart attack before it happens. So my objectives for today's talk will be very clear. I'll be talking about cardiac CT, covering the calcium scores, and coronary angiograms, with some emphasis on the extracoronary, because around the heart you have lung and mediastinum. Now, the first most important topic these days is coronary artery calcium. It's a very simple scan, just walk in, walk out. A low radiation dose. It's a very good predictor marker for atherosclerosis. When we want to scan an individual, a young patient who has a family history or who's falling under an intermediate Framingham score, we would like to go for a coronary artery calcium. It's a strong association between the atherosclerotic cardiovascular phenomena, because as we see the progression of atherosclerosis, the first thing to come into imaging will be calcium. You can very well see this is the LAD, which we can see the speckles of calcification along the left LAD territory. Now, how does this calcium score is important for the clinician? It is a very important marker because it helps in treatment adherence. When I talk about calcium score, it can vary from 0 to 1,000 or more than that. But what tends to happen is, if you have a 0 calcium, it is 97% of the chances that you don't have coronary artery disease. Rest of the 3% might have, which may be soft plaques. So when you have a 0 calcium, you can downscale your treatment according to the risk factors of the patient. When you have a score between 1 to 400, that's an intermediate risk, you can vary the treatment according to the vessel involved, whether be proximal or distal, the plaques, the density. That is known as Axton's calcium score. And if the calcium is more than 400, you have a high risk and you need to intensify your treatment towards according to the risk factors. So to conclude my calcium score, it's a very good modality to screen patients, and especially for asymptomatic. You cannot stop at calcium score for symptomatic patients. You can screen young individuals with a positive family history because they tend to have atherosclerotic cardiovascular diseases. It is a very useful test for treatment adherence because these days we have these MESA trials which can tell you the calcium score, your age of the vessel. You might have a 46-year-old smoker, but his vessels may age up to 60 years. So atherosclerotic score, according to calcium score, has been a very useful for treatment adherence. But for individual testing, you don't know where your patient lies, whether it's in the 97% of 0 score or whether it's a 3% with soft plaques. The next step will be coronary angiogram. It's a very nice comprehensive test for the atherosclerotic disease burden. It helps to risk stratify the patient, whether according to his scoring, you can tell him that whether he has a coronary artery disease or not. And the best thing about coronary angiogram is that you can tell the patient being an obstructive or non-obstructive coronary artery disease. It helps in management. When you have an obstructive coronary artery disease, you can go for revascularization therapies. It has a sensitivity of 95%. Now, the sensitivity is very good. So what does this 99% predicts? If you have a plaque in your coronary angiogram, you have coronary artery disease. But the specificity lies down because the grading of that plaque, I may feel it's only 60%, and some other radiologist might just say it's 40%. The third one can say 90%. So the specificity is a bit low because it is an individual variant. We don't have yet AI softwares to plaque it, give you the final scores like we did for calcium. But the sensitivity is fair enough to explain that you have it or you don't have it. That's what the question lies. Now, what are the indications? Earlier, everybody is scared of radiation. When you talk about coronary angiogram, it's a very walk-in procedure, OPD procedure. You have a cannula, you get a scan done, well off. But now the coronary angiograph has taken a quite higher rank as it was thought to be earlier. It's turned out to be the first line test for intermediate and even for high-risk patients with a typical chest pain. You can also rule out a coronary artery disease in an atypical chest pain because chest pain is one of the common presentations for the emergency departments. It is also the first line test for prior CABG. When you want to evaluate grafts in your CABG patients, you need to inject dye to every graft. If it is occluded, you don't know whether it's working or not. CT is an excellent modality for CABG grafts and stents if they are more than 3 mm or in the proximal. The smaller stents is not sufficient right now with our machines to follow, but maybe in the later stages we can go along with it. It is also a modality helpful when you're going for a pre-op examinations clearance for a high-risk cardiac patients to rule out any obstructive disease. Now, the report which we give you comes as CADRADS. That is a reporting and data system that's standardized. What you tend to understand is that we score our patients from 1 to 5. So the 1 and 2 are the non-obstructive coronary artery disease, where we tend to have plaques causing less than 50% of obstruction. These patients are treated with secondary prevention. They don't need to go any further testing. Comes the third one, which is a bit of 50 to 79%. Now we need to know whether this plaque is causing obstruction or not. Dependingly, we may go for an invasive cath angiogram if the patient is quite symptomatic, or the other way, we can go for an functional imaging. These days, we have stress MRIs with adenosine or stress echoes. When we move up to 4, that is more than 75%, we tend to include the left main vessel. This is a very important vessel because after 50%, we start accounting the patient for obstructive coronary artery disease. So when we say if it is there, more than 50%, we need to go for invasive cath angio, because left main vessel has a different criteria from the rest of the 3 vessels. And if these vessels, all the 3 are involved, more than 70%, we tend to move to the other invasive methods and go for ischemia testing. That's to stress imaging. Then we have this 4S, that is a stent in the artery, you can see, and these hypoechoic areas in the stent are the obstructive parts in the stent. This is known as in-stent restenosis. And the 5th one is complete occlusion. We'll be seeing in the coming slides what kind it looks like, and this definite needs a treatment for revascularization. Can be CABG or dependingly a stent. So the most important question which comes, the dose. With latest techniques and the machines what we are using, there's a minimum dose which is 3 to 5 millisieverts for any angiograms. It is well enough to your background radiations, what you're already facing. When to repeat, it depends on your risk factors. If you are an intermediate with an hyperlipidemia, hypertensive, age factor, and according to your diabetic, you can go from 3, it can range from 3 to 5 years. When you initially had your coronary angiogram, you have cataracts 2, that is non-obstructive. You can wait for 5 years for the next one. And if you are falling in cataracts 3, then you need to repeat within a 3-year span, because it is thought by the latest that you tend to progress in the first 2 years, up to 3 years. Diabetic, you tend to have soft plaques, you need to repeat after 3 years. So to conclude, it's a very good investigation, not only for low to intermediate risk, it's a good investigation for the stable patients also with no prior history of coronary artery disease with chest pain. It's a good screening modality by the latest preventive cardiology journals in 2022 guidelines for asymptomatic high-risk patients. It can be used for pre-op evaluation for to rule out any obstructive coronary artery disease for the risk patients who are undergoing for a major surgery. It is the first-line treatment, first-line investigation for post-CABG and stents more than 3 mm. This 3 mm test has to be considered because right now we can only say in-stent restenosis in the more than 3 mm or the proximal segments. We don't talk about distal stents. And don't be scared of radiation. You have enough of background radiations, obviously. Now moving to this case, this is a 62-year-old male with hypertension and recent chest pain. He underwent a catheter angiogram. This is the LAD. You can see the well filling off with the contrast fully with no plaques. This is again his LCX. And this is his right coronary artery. We can see the walls outside very well and good contrast filling of the lumen. This is cataract 0, no coronary artery disease. The second case is he's a hypertensive with hyperlipidemia and with a chest pain and positive TMT. The echo came out to be normal. This is his LAD, well off, no plaques. This is his LCX, first diagonal, the first branch of the LAD territory. And this is his RCA. You can see this defect filling. This defect, this is a complete occlusion of the RCA territory. He was cataracts 5, a single vessel disease, underwent revascularization with a stent. Now the next patient is a 62-year-old male. He's hypertensive diabetic with intermediate risk factors, so underwent for screening. First, when we start off with any elderly above 60, the most important thing we need to do is a calcium score. Because above 1,000 calcium scores, we tend to have an undercall study. We tend to undercall the patient, he might have a significant arterial disease. So as with the protocol, we move with a calcium score, and you can see this was the first slide I had shown you. And this is the RCA, the PLV branch of the RCA, and there is calcification. According to accident score, he has 533. That shows that he has coronary artery disease. But when we move on to the angiogram, you can see the lumen very clearly, and these calcification, which we appreciated earlier, are eccentric. Now, the beauty of this CT coronary is when you go for an invasive coronary angiogram, the lumen will be normal. So you'll be labeled normal. You cannot see extraluminal calcifications, which are well appreciated on the CT scans. This is another LCX branch, another speckle of calcification with beautiful filling of the whole of the vessel. And this is your RCA, the proximal part, and these again the calcification extraluminal with well of the branches. And this is a complete RCA from the origin till the end. So these are the calcification, but the lumen is well off. My lumen occlusion was less than 40%, classifying into cataracts 2. Can be treated symptomatically. So now the point is the 533 calcium. If I send him back with 533 calcium, he'll be treated intensively. But when I see cataracts 2, it's not obstructing. So why do I need to intensify my treatment? Now post CABG, 62-year-old male with chest pain. Now this is your Lima graft. You can well appreciate this is the origin of the Lima graft, and there your Lima graft goes to your LAD. The whole of the graft is visible throughout the and filling very properly. So that is why it is the first line investigation for the CABG patients. This is a VR, volume dendrite imaging. This is your Lima graft, and this is your SVG graft going to the obtuse marginal. This is cataracts 1G. Why do I say G? G is for graft. All the reporting of cataract should be done in form of G. One is a minimal disease. So he's doing very well. His chest pain is not of the cardiac origin. This is a post-PTCA, the stent I was talking about. This is a diabetic and hypertensive male with a smoker. He is a high-risk patient, underwent a PTCA, that is stent to RCA, 2 years back. Now he has chest pain for evaluation. This is a volume rendered imaging. I can see the stent here. This is the stent which appears different from these arteries. You can see the stent, well patent, all the contrast flowing through. No instant restenosis. But when I move to my main arteries, you can see these filling defects, these tiny filling defects. These are soft plaques. So he's a smoker and a diabetic, a very prone for developing soft plaques. This is my first diagonal, the first major branch of LAD. Again, I can see these plaques here when I rotate them off. And this is my LCX. Again, these plaques are there. So now, how significant? He was labeled as cataracts 3S. Now I've come to the category 3. S is for stent. So he underwent functional imaging, that is stress MRI. And the stress MRI result came negative for inducible ischemia. When he doesn't has an inducible ischemia, that means he has well-developed collaterals. We don't need to intervene, just go for a close follow-up. Now, just a small topic of extracoronary, these days we have these special studies known as double and triple rule-out study. By meaning, I want to say is that when an acute chest pain patient comes, we can do a double angio, that is rule out pulmonary embolism with a coronary artery disease, or a aortic dissection from coronary artery disease, or we can have triple rule out, that is pulmonary with coronary with aortograms. So this patient was undergoing a calcium score acute chest pain, 62-year-old male with few speckle calcification, but what I notice in my calcium score is there is a hematoma around the aorta. I go for a double rule out study and I see a dissection flap in the patient, and this dissection flap was extended all through the abdominal aorta. It was a type B Stanford dissection. And there you can see a pulmonary thrombus accumulating, patient presenting with chest pain, and then secondary finding of pleural effusion. Thank you. Yes, ma'am? Yes, sir? A coronary angiogram, it takes 5 minutes, sir. 5 minutes, totally 5 minutes. 3.4 seconds for the calcium score and 5.6 milliseconds for the coronary.
And how many beats? In how many
Sir, it depends on your machine. If you have a slice section of 4, that depends on how long it, like with 128 slice, we have 4 centimeter that goes at a time. So we have to take 3 skip views. So accordingly, it depends on the how big your heart is. Generally, we consider it to be 12 centimeter. So there will be 3 slice gaps.
Thank you, madam.
Welcome, sir.
Common modality.
Yeah.
Actually, in our day-to-day practice, we used to see patients of non-cardiac chest pain. We used to see in Dhanvantri, room number 1, line is very long, is room number 2, that is cardiology OPD. Everybody is coming with chest pain. Right side chest pain, no problem. But left side chest pain, problem in chest as well as in mind also. So psychogenic chest pain बहुत होता है. coming to our OPD from room number 2 to room number 1 कि सर उन्होंने देख लिया ECG नॉर्मल है, एक्सरे नॉर्मल है, देयर इज नथिंग, यू कैन गो टू रूम नंबर 1, मीन्स दैट इज जनरल फिजिशियन OPD. Patient come to us with non-cardiac chest pain, mostly in GERD form, that is gastroesophageal reflux disease. So if patient is coming to you with chest pain, then you can rule out by ECG, TMT and echo. These are basically non-invasive investigations. If you want to ask some patient that I have to admit you in our hospital for coronary angiogram, everybody will refuse first time. No sir, ECG is normal, echo is normal, sir आप तो बिना कोई जांच के कर लीजिए. At that time, this investigation is nice modality. If you rule out and you have to satisfy your patient कि यार तेरा मैंने एंजियोग्राम कर लिया, CT coronary angiogram कर लिया, that is normal. So अब तेरा दिमाग से chest pain खत्म हो गया. So it is nice modality of investigation to rule out. And again I would like to add one thing. If patient is coming to you with chest pain, then you can ask to your patient about upper GI endoscopy to rule out reflex esophagitis. Thank you.
Thank you.
Thank you, Dr. Prerna. Next speaker, once again, Dr. Seetu Singh. She will be talk on how to diagnose ILD in my clinical practice. Dr. Seetu.
Very good morning to all of you. So I think ILD, whenever an ILD patient walks in, it is always, we are fearful. Oh my God, how will I diagnose? How will I treat? So ILD is that monster I think all of us are scared of in the dark. But in reality, it is the orphan that requires our attention and care. An ILD patient would be requiring, the first time when he or she visits would be probably half an hour of your time. You need to spend time with your patient and get to the bottom of the cause that why this particular patient is having this disease. The symptoms of ILD are non-specific. They may be that of an asthma or, sometimes like an exertional dyspnea may present with a cardiac complication. So dyspnea on exertion, cough, which is usually dry, loss of weight and appetite, and fatigue. Wheezing, hemoptysis, chest pain are rare. In the ILD India registry was one of the largest study that we conducted, multi-center study, and out of 1,084 patients that we recruited, we found that the most common symptoms were dyspnea and cough, and these are very non-specific, can be due to any disease. Physical examination does give us some pointers, and these include clubbing, velcro rales or basal crepitations. In the registry, we had almost 79% patients who were having these basal crepitations. One of the very classical signs for a patient, one second. So let me just briefly tell you about velcro rales. These are similar to, the velcro that we hear, the sticking in and sticking out, and similar to that is the velcro. I think there's a problem with this video. Let me see if you can hear. Audio chal raha hai na? So between the inspiration and expiration, you hear a squeaking sound, and this squeaking sound is very classical of hypersensitivity pneumonitis. It's a type of ILD which is the most common ILD in our country. So कई बार ये wheezing की तरह सुनाई देगी, कई बार आप ध्यान से सुनोगे तो इंस्पिरेशन में ही होती है और इसे स्क्वीक्स कहते हैं. So I will propose a diagnostic algorithm which will help you to diagnose your patient quickly even in a very busy OPD. So suppose your patient presents with cough and exertional dyspnea. You go ahead with very basic 3 tests which are cough, 6-minute and a spirometry. Can be done easily, cheap, inexpensive with no radiation exposure. An X-ray can give you clues. Another thing, if you have one X-ray, try to ask the patient to bring all the old X-rays and try to compare. Some lung volume loss, reticulations, basal predominance in certain ILDs and an upper lobe predominance in the other ILDs will give you clues. However, there is another rider here. 10% of the chest x-rays may be normal. The second investigation, we've already had a brilliant session yesterday on spirometry. If you find a spirometry, come on, now you are going to help me solve this spirometry. What is the first thing that you need to see in a spirometry? Very good. Is it normal? So anything more than 70% is normal. So what is the next thing that you see? FVC, very good. My job is half done. So is it normal here? It is 60%. How much should it be? More than 80. So it is a suggestive of restriction. So spirometry only suggests restriction. It does not diagnose. So you have a X-ray if it is abnormal, and you have a spirometry that shows restriction. The third test is the 6-minute walk test. So 6-minute walk test is a simple and easy test to perform. Ask the patient to walk for 6 minutes on a 30-meter long corridor. Check the saturation before and after. More than 4% drop would be indicating either ILD or a pulmonary vascular disease. So if your patient has pulmonary hypertension, then also there will be a drop of more than 4%. So 3 tests, an X-ray, a spirometry and 6 minutes, and you will be able to clinch the diagnosis. So whenever your patient in this very busy outdoor comes to you very breathless, the patient comes and sits, then he is comfortable. Then you suspect that this can be an ILD because patient is now very comfortable. Second thing, listen to the basis. Never ignore physical examination. These are windows for the diagnosis. You hear Velcro rolls. You examine clubbing. 6 minutes, you just, even if you don't get the full time, you ask the patient to walk a little bit and the saturation dips. These are all indicators. Keep the threshold low for getting a CT scan. The rider for getting a CT scan is a good quality scan. The scan should be of appropriate quality. Otherwise, you will not be able to interpret it. So this was a small experiment that we did. This is a brown bread which was a thicker section, and we cut it more finely and the thinner section. What is the difference that you see? Here, can you appreciate the architecture of the bread? No. And in this, what you can see is you can see everything clearly. Same is the difference between a normal CT scan and a HR cut. So what you can't see here, you can see very clearly here. So whenever you are suspicious of ILD, always get prone cuts and an expiratory scan, especially to look for air trapping. So I will be dedicating few slides on HRCT interpretation because this is important. So you have to see the hallmark sign for an ILD is a honeycombing. Whether there is honeycombing, yes or no. What is the predominant pattern? Is it reticular, ground glass, nodular, consolidation, cystic, or a combination? What is the distribution? Upper lobe hai, lower lobe hai, kahan pe hai aapka disease? अच्छा, second part is बाहर की तरफ है, अंदर की तरफ है, subpleural है या peribronchovascular है. And the thing that has not to be missed is anything else like mediastinal glands or a dilated esophagus that may be seen in systemic sclerosis. So I think the most important thing that I would like you to take from this class is to identify honeycombing. So what is actually honeycombing? These are layered cystic spaces, subpleural distribution, they share walls. You need to have 3 layers at least. So ये दिख रहा है आपको? ये छोटे छोटे से बॉक्सेस बने हुए हैं, ये 1, 2, 3, 4, ये वॉल शेयर कर रहे हैं. इसको आप किससे कंफ्यूज कर सकते हो? सो द डिफरेंशियल्स ऑफ हनीकूमिंग. सो पेशेंट जनरली हनीकूमिंग इफ इट इज़ IPF, इट्स अ स्मोकर. स्मोकर्स को और क्या हो सकता है? एम्फाइसीमा. सो व्हाट डू यू सी इन दिस स्कैन? So these black areas which do not have walls, they are not subpleural. These are, come on, सेंट्रीलोब्यूलर एम्फाइसीमा. तो जिसको सेंटर लॉब्यूल दिखता नहीं है पर इनका लंग ब्लैक होता है. द सेकेंड डिफरेंशियल इज दीज आर सबप्लूरल, Some of them are sharing walls, but they are not 3 layers. What is this? पैरासेप्टल एम्फाइसीमा. ये भी स्मोकर्स में मिलता है, ये हनीकूमिंग नहीं है. अनदर इम्पॉर्टेंट डिफरेंशियल ये क्या है? सो इफ यू सी, हाँ, दीज आर मोर सिस्टिक, बिगर, एंड इफ यू ट्रेस देम, अगर इसमें आप डाइकॉम इमेजेस मंगा लेंगे, आस्क द पेशेंट टू गेट अ सीटी स्कैन, फॉलो द इमेजेस अप एंड डाउन, they will be actually bronchi which are dilated. So this is bronchiectasis. Next part is the predominant pattern, which may be reticular, ground glass, nodular, consolidation, cystic, and a combination. So now tell me here, what is this pattern that we see? ये क्या है? तो एक सेंट्री लॉब्यूलर मतलब एक नोड्यूल है, लॉब्यूल है, लॉब्यूल के अगर वॉल्स थिकंड है तो ये कौन सा पैटर्न आ रहा है? अ रेटिक्यूलर पैटर्न. इसमें क्या दिख रहा है? कुछ पार्ट सीटी स्कैन का वाइट है, कुछ ब्लैक है. तो जो वाइट पार्ट है, ऑलवेज लुक एट द ट्रेकिया, एनीथिंग उसमें जो एयर दिख रही है, अगर उतना ब्लैक आपका लंग नहीं है तो वो क्या है? लंग में ग्राउंड ग्लासिंग है. सो दिस इज अ मोर ऑफ ग्राउंड ग्लास विथ सम एरियाज दैट आर ब्लैक विच कैन बी सीन इन एयर ट्रैपिंग. सो इन दिस पर्टिकुलर पेशेंट यू आर गोइंग टू हेल्प मी. इसमें छोटे छोटे नोड्यूल्स दिख रहे हैं, है ना? तो कौन सा पैटर्न हो गया ये? कैन आई हैव अ कॉलर माइक प्लीज? तो ये छोटे छोटे नोड्यूल्स दिख रहे हैं, ये कौन सा पैटर्न है? नोड्यूल्स कहाँ से जा रहे हैं? आर दे पेरी ब्रोंकोवैस्कुलर, सेंट्री लॉब्यूलर और रैंडम? तो जो भी सेंटर से पेरिफेरी की तरफ जाता है वो पेरी ब्रोंकोवैस्कुलर होता है. चलो ठीक है, कोई बात नहीं. तो दिस इज पेरी ब्रोंकोवैस्कुलर पैटर्न. आपको दिख रहे हैं नोड्यूल्स? येस और नो? तो दीज आर वेल डिफाइंड डिस्क्रीट नोड्यूल्स. So the answer here is these are nodules with peribronchovascular pattern and you can see them, they are discrete. अच्छा, इसमें क्या दिख रहा है? छोटे छोटे नोड्यूल्स हैं, है ना? सारी जगह है. लॉब्यूल जो सेकेंडरी लॉब्यूल के बीच में है, तो क्या होगा? सेंट्री लॉब्यूलर. दिख रहे हैं क्या? आई थिंक कुछ लोगों को दिख रहे हैं, कुछ को नहीं दिख रहे. सो दे आर इल डिफाइंड. सो द आंसर इज दीज आर सेंट्री लॉब्यूलर नोड्यूल्स एंड दे आर इल डिफाइंड. तो जब आपको बहुत ध्यान से देखना पड़ता है, दिस इज पर्टिकुलरली सीन इन अ डिजीज हाइपर सेंसिटिविटी न्यूमोनाइटिस विच इज़ द मोस्ट कॉमन ILD इन आवर कंट्री. इसमें नोड्यूल्स दिख रहे हैं? येस और नो? रैंडम से हैं, तो दीज आर रैंडम नोड्यूल्स विच आर डिस्क्रीट. अनदर इम्पॉर्टेंट थिंग इज कि सपोज एक तो होता है लंग वाइट दिख रहा है, उसमें वेसल्स दिख रही हैं, उसे ग्राउंड ग्लास कहते हैं. अगर लंग वाइट दिख रहा है पर वेसल्स नहीं दिख रही, उसको क्या कहते हैं? कंसोलिडेशन. जैसे निमोनिया वाला फर्स्ट था, तो सिमिलर टू दैट. तो दैट वाज अ स्लाइड ऑफ कंसोलिडेशन. व्हाट इज दिस? दीज आर ब्लैक एरियाज विद वॉल विच आर थिक. You can see the walls exactly. They are not sharing. These are cysts. So many ILDs also have cysts. So again, who's going to tell me which pattern is this? ये सारे इंटरलॉब्यूलर सेप्टल थिकनिंग दिख रही है ना मार्केडली. और क्या है यहाँ पे सीटी स्कैन में? What is this? An effusion. Very good. तो दिस कैन बी सीन इन अ हार्ट फेलियर पेशेंट. तो मैनी टाइम्स हार्ट फेलियर पेशेंट्स पे ILD का लेबल लग के आ जाता है. तो प्लीज़ कीप इन माइंड स्मूथ इंटरलॉब्यूलर सेप्टल थिकनिंग विद एन एफ्यूजन कैन बी सीन इन अ पेशेंट ऑफ हार्ट फेलियर. दिस इज नॉट ILD. सो जोनल प्रीडोमिनेंस के लिए अपने पास में कुछ और स्कैन्स आते हैं विच आर कोरोनल और सेजाइटल. सो वट यू कैन सी इज अपर लोब्स आर स्पेयर्ड, लोअर लोब्स are involved. So it is a lower lobe predominant disease and it is subpleural. तो ये प्लूरा है, प्लूरा के नीचे नीचे डिजीज़ है. तो लोअर लोब में है, प्लूरा के नीचे है, सबप्लूरल डिजीज़ है. If you don't have those coronal and sagittal scans, you can follow these scans. ये अपर से लेके नीचे जा रहे हैं लोअर लोब में. तो इसमें कहाँ पे है डिजीज़? अपर में है. बेसिस देखो, लिवर के ऊपर सब चीज़ें साफ है. So it is an upper lobe predominant disease. So just one thing, typical UIP I will help you identify is if you get honeycombing It is a typical UIP pattern, multiple layered stacks, subpleural. अब ये देखो यहाँ liver चालू हो गया, तो you can come to know this is basal predominant disease. You do need to see the upper lobe, but this is a basal predominant. So if you have a typical UIP with no identifiable factor, it is diagnostic of an IPF, particularly in an elderly male smoker. So to confirm the diagnosis of ILD is no less than a work of Sherlock Holmes. You have to pick up innocuous looking clues. So we have come here till the algorithm. You have the CT scan. Again you reassess the history. At this point you ask connective tissue disease history. आपके joint pain है, Raynaud's है, do you have muscle weakness? Are you able to comb your hair? You ask for exposure history. Do you have exposure to pigeons, molds, farming exposures? You ask whether you are a smoker or not. And if you have a diagnosis of UIP or a patient with a CTD history, you don't need to go ahead. And finally, you have a confident clinical diagnosis of either IPF or connective tissue disease. If you don't have this, you need to get your patients a biopsy. Quickly, initially we were doing transbronchial lung biopsy. उसमें piece छोटा आता था. Many times we did not get a diagnosis. So, the new kid on the block is a cryo lung biopsy, in which we get a bigger chunk of tissue without being invasive. We go through the bronchoscope and take bigger chunks. And this is one particular patient, 45-year-old male with some basal ground glassing, some air trapping, patient not responding. We did a biopsy which showed hypersensitivity pneumonitis. So with this, I sum up my talk, and if you would like to ask questions, please go ahead.
Thank you, Sidhu. Very well explained about the ILD, every aspect, diagnosis to and everything. Anybody answer? Anybody question? Any question?
Tuberculosis. So tuberculosis में interstitial lung disease नहीं होती, इसमें post tubercular fibrosis and bronchiectasis होता है. But many of these patients do have respiratory failure. But the classical ILD is not there. It is post-tubercular lung damage in the form of fibrosis, cavitation and bronchiectasis. So that is not actually ILD. You can give it another term. Many people give, actually you see an obstructive airway disease. So post-tubercular OAD is more common. Yes. Yes, so I think COVID, all scans, half of them were either, even our ILD patients are being given reports of COVID CT scans. This is a wonderful question, really of context to us. So you have to, even we have to spend lot of time whether to find out, try to get CT scans prior to his COVID. If he has an ILD before COVID, it was ILD to start with and just an exacerbation of ILD probably during the COVID. Now the COVID associated reticulations should go away. It is not a progressive ILD, they should go away. We have still encountered couple of patients in whom the ILD or the post-COVID fibrosis is progressing, and in those particular patients we try to evaluate whether it is ILD. We get a CTD panel, go into the history, get a HP, and many of these patients we are also taking them up for cryobiopsies to find out whether this is actually ILD or a post-COVID fibrosis. Okay, so I didn't actually take that topic. I think that's they are murky waters. We don't know. So the answer is I don't know whether nintedanib or pirfenidone will work in post-COVID fibrosis. Till now, we only have evidence of using these drugs in IPF and certain connective tissue disease associated ILD like systemic sclerosis associated ILD. So some fibrotic ILDs you can use, but the evidence about post-COVID fibrosis, I don't know. Regarding my personal experience, I have used it, but I don't give it for long, 3 to 6 months, that's it.
Thank you, Sidhu. Next.
Now I would like to invite Dr. Prashant Vasne for his lecture. The topic is approach to hypotension. That is very common and helpful in our day-to-day practice. Dr. Prashant Vasne.
Dr. Prashant is consultant cardiac anesthesia at RHL Hospital. After completing his DA from TNMC BYL Nair Hospital, he pursued his DNB from Kokila Bain Hospital, Mumbai. He is a very dedicated and dynamic doctor, taking care of very high-risk patients right from the cath lab to the cardiac ICU. I now invite Dr. Prashant to the stage.
ये लैपटॉप हटाओ चार्जर लगेगा इधर अब कर है Hi. Basically, today we are dealing with a very common symptom which we get in OPD, which we get in ER, and I'll be dealing more of a patient when we deal in ER or in OPD, when we get a first touch of the patient. So blood pressure is a force exerted against the wall of the arteries as the heart pumps out the blood. And blood pressure itself is a product of cardiac output and the systemic vascular resistance. And cardiac output is a product of your stroke volume and heart rate. And stroke volume itself is dependent on the preload, heart contractility, and the afterload. How you define a hypertension? When the patient is presenting with the absolute blood pressure of less than 90 and the diastolic pressure of less than 40 and the mean pressure of less than 60. But there are some other types of hypertension are there. There's orthostatic hypertension, which says when the patient stands and there is a fall in pressure of systolic pressure by more than 20 and the diastolic pressure of more than 10, it says the orthostatic hypertension. When profound hypertension is that when the patient is requiring high doses of vasopressors to maintain the mean pressures. And the relative hypertension is that the patient is a hypertensive and he has got a blood pressure of around 110 and there is a drop of pressure of more than 40. That means there is a relative hypertension, but still patient can be symptomatic. What are the symptoms the patient present with of hypertension? Patient with dizziness, confusion, there is a decreased urine output, nausea, vomiting will be there. Now, hypertension is something you get a very commonly in the OPD, but it can be a sign of a shock. So shock, what is a shock? Shock is a momentary pause in the act of the death. Basically, if you don't intervene there, the patient will end up in some complication. The shock is defined as a state of cellular and tissue hypoxia due to reduced oxygen delivery and increased oxygen consumption or inadequate oxygen utilization. But every patient who is getting hypertension is not in shock, and every shock doesn't present with a hypertension, because in initial stages there will be a state of compensatory mechanism and patient will have some degree of normal BP over there. In initial evaluation, what you are supposed to do? You have to define whether is this just a shock or is just a hypertension. So how you will define? Basically, you have a tachycardia, oliguria, abnormal mental status, tachypnea with cool clammy cyanotic skin, metabolic acidosis, and hyperlactemia, along with hypertension. If these are present, these are the very sentinel signs, but these are pertaining to your shock. You can go for general examination for every patient. You're supposed to check the sensorium, mucous membrane, neck veins, whether they are dilated and collapsed. You have to see the skin, whether it is dry and moist. Go for the cardiac examination and systemic examination, and you will find the particular findings according to the type of shock over there. What will be our initial approach to the patient presenting with the hypertension? So first, we have to define whether patient is in shock. So if patient is having typical symptoms like tachycardia, tachypnea, oliguria, altered mental status, the patient is in shock. But if patient doesn't have these symptoms, patient is not in shock. So what are the common causes of patient having hypertension but no shock? Is that patient is chronic hypertensive. The patient's BP is always remaining around somewhere around 90, 100. That is acceptable. Then it may be drug induced. Patient may have taken the overdoses of the antihypertensive, diuretics. The second thing is autonomic dysfunction. Third thing is vasovagal syncope and the peripheral arteries. In peripheral arteries, what happens is there is a plaque in the some artery. You have measured the BP in the same limb. You are supposed to measure the when you are getting the low BP, you are supposed to compare the blood pressure in the both the arms. There might be a possibility that the patient is having a peripheral artery disease, and you might get the proper pressure in the next other arm. If the patient is having a shock, secure the airway, maintain the oxygenation, get a good IV bore access, take a blood sample, administer a fluid bolus. Just be cautious administering in fluid specifically in the cardiogenic shock when the patient is have a evident finding of a pulmonary edema. And there are some life-threatening conditions like anaphylaxis, tension pneumothorax, cardiac tamponade, hemoperitoneum, hemodynamic significant arrhythmias, and pulmonary embolism. In these conditions, we are not supposed to take a detailed history. We are supposed to take a focus history, and we have to intervene over there. Because if we wait for taking the history, get the lab investigations, then the patient will succumb to cardiac arrest, and we are not letting the patient to die over there. So we are supposed to intervene over there, and simultaneously we'll do the taking the history, and simultaneously we give the fluid and use the vasopressors over there. The thing is that now the patient is having a shock. If there is a life-threatening condition, intervene over there, stabilize the patient, then take the detailed history and all investigations. If patient doesn't have any life-threatening condition, you directly go to the detailed history and clinical examination of that patient. And what will be the initial management of the patient? It is always A, B, C, and D. The CAB is for the cardiac arrest patient, but patient is in shock, patient is having a trauma, then always it goes with the A, B, C, and D. A is supposed to be airway, B is breathing. In breathing, we are supposed to maintain the oxygenation of the patient. At what time we are supposed to intubate the patient? If the patient is not able to maintain the oxygenation, if there is hypercarbia and there is evidence of increased work of breathing, then we are supposed to intubate the patient. Otherwise, there is no need to intubate the patient. In circulation, we are always having this whether we are supposed to take a peripheral IV or whether we are go with a central line. So if we take a good peripheral IV of around 16 gauge in the both arms, so a 16 gauge IV can deliver around 10 liters of fluid in an hour. And if you take a central line of a 7 French, it delivers hardly 7 to 7.5 liters of fluid in an hour. That means a 16 gauge IV is better than a center venous line in delivering the fluid. So initially we can take the peripheral line. If required, the patient is having a persistent symptom of the shock, you can go with central line. And if you need to take a repeated samples for the blood, you need to monitor CVP, then central line is useful in those patients. And always assess the disability. When the patient comes to the trauma, always assess the disability in those patients. So any evidence of shock, then start resuscitating there onwards. Maintain mean BP of more than 65 to 70. Give IV fluid boluses accordingly, and always see whether after giving every bolus the perfusion pressure is increasing or not. If it is not increasing, then search for some other causes. Add vasopressors if the patient is not responsive to the IV fluid therapy. What is your endpoint of IV fluid therapy? So when you are supposed to stop the IV fluid when you have achieved the perfusion pressures. Second thing, there is evidence of pulmonary edema or the abdominal hypertension, and there is the fluid is failed. Basically, fluid therapy is failed to augment the blood pressures, and always there is a caution in giving fluid to cardiogenic shock patient. What investigation you are supposed to send at the first visit of the patient? Get an ECG, take a blood sample and send CBC, cardiac enzymes, pro-BNP, coagulation studies like D-dimer, serum lactate, and blood gas analysis. And in imaging, I think everywhere it is available like X-ray, CT scan, and USG. And in USG, we can do 2D echo, then we can do abdominal USG and the thoracic USG. And when the patient is still, you are not able to define whether the patient is what type of shock is there, the pulmonary artery catheter is the last thing which you are supposed to put, and evaluate the patient according to cardiac output, SVR and PVR, whether he is in which type of shock he is. So these are the type of shocks: distributive, hypovolemic, cardiogenic, obstructive, and combined. So we'll be dealing with basically mainly the initial management of these shocks. These are the normal values which you get. So always remember these values, but always remember that we are not going to treat the values. We are going to treat the patient. If we are getting the increasing trend of the some values or decreasing trend of the value, we'll consider those. In distributive shock, there is a decrease, and preload is normal. Your pump, that is heart contractility, is normal or increased. It may be hyperdynamic, and afterload is decreased. But SCVO2 is increased. Normal SCVO2 value is around 70. Mixed venous saturation is around 65. So if it is more than 70, that means it is distributive shock. So what are the examples? That is sepsis and SIRS, spinal cord injury, anaphylaxis, and adrenal crisis. We'll be dealing with these things. In sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to the infection. Sepsis is a clinical diagnosis which is supported by your lab diagnosis. It is not something which is like a patient is having pulmonary embolism. The gold standard is CTPA, but there is no gold standard to diagnose a sepsis. Okay, and even if you get a procal done, the procal is not a good diagnostic marker. It is a prognostic marker. Plus, you can decrease your antibiotic therapy on the basis of the procal values. Okay, the clinical features of the sepsis are like some predisposing factor. The patient has a recent ICU admission, patient has a recent indwelling catheter inside, central line insertion, fever, hypothermia, tachycardia, tachypnea, any evidence of pus collection, so are sepsis like, history of drug abuse in prosthetic heart valve patients, and other signs of shock, which I explained earlier. In labs, you will get leukopenia, leukocytosis, normal counts with 10% of immature forms, increased CRP, thrombocytopenia, deranged coagulation profile, and focus on infection on imaging. If you get these, the patient is having a high probability of infection, sepsis. So what will be the management of these patients? Send a culture immediately, send a urine routine and culture again, and IV fluid bolus of around 2 to 3 liters patient will require if he is having a pure sepsis. And administer broad spectrum antibiotic like Tazect and some carbapenems within the first hour. If you delay the dose of the antibiotic, there is more probability of getting more complication of the sepsis. Again, if a patient comes to us, polytrauma patients comes to you. A polytrauma patient come with a multiple site pains. It is very difficult to relate the where he is exactly having a fractures and everything. So you have to be very cautious and always see the sensation level, motor activity of the limbs and arms, and always see that exactly the where he is having the location of the pain at the level of the spine. If he is having these symptoms, so that means it is a spinal cord injury, and that means that below the level of the injury there is a loss of sympathetic tone, and that will lead to pooling of the blood in the lower extremities, and so the patient will present with the hypertension in these patients. So what we are supposed to do, we are supposed to give IV fluid boluses. In these specific patients, spinal cord injury, traumatic brain injury, we are supposed to maintain the mean pressure of around more than 85 to 90. Management of bradycardia in these patients, if the spinal injury is high, there is a high possibility of getting a bradycardia. So always be cautious about these things, and excess fluid can cause cord edema to these patients, and because the cord injury is there, the bladder bowel is always involved, so catheterize the patient. In adrenocolitis, the patient have a history of primary Addisonian disease. It might be some stress factor, some infection which has aggravated it. Some patient is known higher Addisonian with insufficient doses, or patient have been given steroids, but the withdrawal of the steroid has been sudden with the supraphysiologic doses. These patients can present with severe hypertension and adrenal crisis. And one of the features of the electrolyte is there will be hypernatremia and hyperkalemia in these patients. So what we are supposed to do, we are supposed to give IV fluid 1 to 2 liters. These patients have a propensity to get hypoglycemia also, because there will be unopposed action of the insulin in the body. So there will be a possibility of getting hypoglycemia. If there is sugars are normal, then you can give with normal fluids. Otherwise, start DNS. Injection hydrocortisone 100 milligram bolus followed by 200 milligram over 24 hours, or you can give 50 milligram 6 hourly. The third scenario of distributed shock is anaphylaxis. Anaphylaxis, it is what is an anaphylaxis? Basically, it is in acute onset. Your patient will be having urticaria, pruritus, rash. There will be angiogenetic edema, wheeze, stridor, and later on arrhythmia and cardiac arrest. So in these patients, first we have to see whether the patient is exposed to the known allergen or unknown allergen. If the patient presenting with a known allergen exposure with a hypertension, that means it is an anaphylaxis. Okay, but if patient is exposed to an unknown allergen, so we need 2 or 3 more signs like skin, mucous membrane or respiratory system should involve, and with hypertension, then we label it as anaphylaxis. The drug of choice is epinephrine IM, 0.3 to 0.5 milligram. There is no absolute contraindication to epinephrine in these conditions. Always give oxygen support, nebulization to these patients, give IV fluid 1 to 2 liters. If patient is not responsive to these, give epinephrine infusion, vasopressors, and if patient is on beta blockers, the patient will not respond to epinephrine because your beta receptors are blocked by the beta blockers. So you are supposed to give glucagon. And what we give is Avil and Hydrocort. These are the adjunctive therapies in these patients. Now second shock is hypovolemic shock. There is a preload reduction. That means neck vessels are collapsed. pump functions is normal, but in later stages it will depress because the preload is decreased, so cardiac output will also decrease, and afterload is increased just to maintain the blood pressure, and SCVO2 is normal or decreased in later stages. So what type of shock you will get is hemorrhagic or non-hemorrhagic. In hemorrhagic also you will get a traumatic and non-traumatic shock. In traumatic there will be external injury like fractures, lacerations. In internal injury you will get a pneumoperitoneum, hemothorax, hemopericardium. In non-traumatic, variceal bleed, hemorrhoids, rupture ectopic, PPH, RPOC, and ruptured aortic aneurysm. In non-hemorrhagic, there is a through skin losses like heat stroke, skin. Then renal, there is a renal tubular acidosis. In GI, you will have dysentery, diarrhea, vomiting, and third space loss in the form of pancreatitis. In hemorrhagic shock, you are supposed to give fluid initially, just to buy time and to call for a blood. Not fluid is not the main therapy for the hemorrhagic shock, because if you keep on giving the fluid, that will dilute the clotting factors, and the patient will end up in coagulopathies. And if you don't have blood for the particular blood group, you can transfuse O positive blood group. But the patient is from reproductive age group, you are supposed to transfuse the O negative only. And if there is external bleeding, put a pressure over there. If there is an internal bleeding, always go for intervention. And for non-hemorrhagic shock, the mainstay is IV fluid, balanced salt solutions, or NS, depending on the electrolyte and the metabolic imbalances of the patient. Identify and treat the etiology. Predict whether to give the blood or not. There is a 4-point this thing. Okay, whether injury is penetrating, whether positive fast. Fast is USG assessment in the ER. Systolic BP of less than 90 and heart rate is more than 20. If patient is scoring more than 2 points, that means patient will require blood in the near time. And DDs of shock in the trauma, with the patient presenting with low CVP as external hemorrhage, internal hemorrhage, fractures, third space loss, and high spinal injuries. But patient presenting with shock in after trauma and with high CPR, high CVPR, tension pneumothorax, and cardiac tamponade. Ma'am, should I continue? There are more 5-10 slides. Should I continue? There are 5-10 more slides. Then cardiogenic shock. The cardiogenic shock, there is a increased preload. That is basically there will be failure. Decreased pump function. Cardiogenic shock says there is decreased contractility of the heart and increased afterload just to maintain the SVR, and decreased SCVO2. Raised GVP, distended neck veins, pulmonary edema, diffuse crackles. The most common reason for the cardiogenic shock is MI. As you can see on the ECG also, there is crushing pain, acute dyspnea, gallop rhythm, increased cardiac enzymes, and if there is involvement of the more than 40% of the myocardium, there is a high possibility of getting a shock, cardiogenic shock in these patients, or pulmonary edema in these patients. What you are supposed to do, whether you are supposed to give fluid or not, you can give fluids, but it should be guarded. When you have an auscultation, you have a finding of pulmonary edema, you are not supposed to give fluids. Always administer vasopressor with some diuretics. If patient doesn't have crackles, doesn't have pulmonary edema, you can give small boluses of fluid like 250 ml. If patient responds to that, keep on giving those. If patient doesn't respond, start vasopressor. What vasopressor you are supposed to start in cardiogenic shock? The best vasopressor is noradrenaline, because it doesn't have a more of a beta activity, it has a more of a alpha activity. It will not increase the cardiac workload by increasing the cardiac heart rate, and still patient is not managing on these things. There are some mechanical security devices, we call it IBP, Impella, and LVAD, and ECMO. And early revascularization is the main task. If cannot be done, if you are at periphery, go for fibrinolysis. And beta blockers should be avoided in cardiogenic shock. Till the patient get clears of the cardiogenic shock, you are not supposed to give the beta blockers. When this MI get complicated, you have done the PCI of this patient, MI get complicated after 1 to 2 weeks. There is a duration of 3 to 4 weeks also. The patient get post-MI VSR, we call it VSD, post-MI mitral valve collapse, and post-MI free wall rupture. In these conditions, patient will present with a profound shock after 2 or 3 days or after a week. And patient will require emergency or urgent surgery. Arrhythmias are there for cardiogenic shock, sudden onset palpitation, giddiness, syncope, and there will be tachyarrhythmia and bradyarrhythmia. For tachyarrhythmia, synchronous cardioversion if patient is symptomatic and hypertensive. And if refractory, then increase the energy and you can add the antiarrhythmic drugs. And bradyarrhythmia, you can give atropine, start infusion of dopamine, epinephrine, and if it is still not responsive, you can go for TPI if it is available at your center, or you can transfer the patient to other center. An obstructive shock, there is a tension pneumothorax, one of the example of obstructive shock. And in what happens in obstructive shock, there is a because of the increased air in the pleural cavity, there is a decrease in venous return. So preload is decreased to the heart basically, but neck veins are distended, and the heart is not having a blood or fluid inside, so it cannot pump out the blood. So it will have, the patient will collapse. The treatment of this thing is needle thoracotomy or tube thoracostomy. And pulmonary embolism, one of the example of the obstructive shock. High risk for DVT patients. You always go for the well score. Patient have had cancer, recent lower limb surgery, immobilized for 3-4 days, sudden onset dyspnea, hemoptysis cuff. These things are present, suspect pulmonary embolism. Go for D-dimer, go for 2D echo. On 2D echo, just sir have told, you will get RV hypokinesia, dilated, clot in transit, compression venous USG can be done, and CTP is a gold standard. And if there is a positive finding, you can go for thrombolysis if the patient is hemodynamically unstable. These are the few things which you remember on the when the patient.
Dr.
Whether the
Prasad,
patient,
please
yes.
pass.
Yeah, so 1 or 2 slides, hardly. Whether the patient is responsive to the fluid or not. With traditional markers of the fluid responsiveness are the central venous pressure and the PA catheter. And on controlled ventilation, we can use the PPV, that is the pulse pressure variation, stroke volume variation, and the plethysmography velocity index. Basically, you get a variation with every air respiration in the stroke volume, and because of that, you will get the sway in the you can waveform of the pulse ox and the arterial waveform, and that suggests you the patient is depleted of the volume, and with every breath the stroke volume is changing. Okay, and what fluid you use for the crystalloid, whether you use crystalloid or colloids. So basically, colloids are not good for the resuscitation because it can lead to AKI, and there is an increased incidence of mortality. Whether you use normal saline or albumin doesn't have any benefit over the saline. So always go for saline. Anything else?
Thank you, Prasad. Hypertension is a very big topic, I think.
I agree.
So now, Dr. Anupriya, the session is over.
Thank you, respected chairpersons, for your time.
Thank you.
I would now like to invite our chairpersons for the next session. Dr. Manoj Mali, sir. Dr. Sharad Tikkiwala. Dr. B.B. Sharma, sir.
Sorry.
The next topic for the day is Pulmonary Rehabilitation, A Ray of Hope. The talk will be delivered by Dr. Virendra Singh, sir. I request sir to please come to the stage.
कॉलर माइक लगा दो यार, बताइए आप। वो दे दो मुझे पॉइंटर। At the outset, I am thankful to you all, and we will be discussing pulmonary rehab. Usually, a notion about pulmonary rehabilitation is that it is a few exercises and that should be advised and that should be repeated. But suppose there is a sedentary person and his capacity is only walking 1 to 2 kilometers. But with practice, he can become a long distance walker covering 40 kilometers. We are not surprised in this. A sedentary person with practice reaches to Mount Everest. We are not surprised. So if we extrapolate this principle into our patients, where there was from a sedentary to Mount Everest climber or a sedentary to a 40-kilometer walker, there may be 10 times, 20 times or 100 times in increase in efficiency, and if we translate this efficiency in our patient than a person who is able to walk 5 meter. If 100 times, then it is half kilometer. That transforms quality of life into dramatic way. I will be discussing couple of the patients mainly during the COVID era who were given pulmonary rehab, and I will be sharing the results with you. Next please. Acha, okay. Can you next do that? Okay, then I have to do it. Okay, here is a patient who is admitted, lady patient, 14th May 21. You can see that there is acute COVID pneumonia. You can do. And on day 20th, can you note something? It is here. There is a cavity. And usually COVID goes away in a week or two, but it leaves behind the marks, and those marks is fertile ground for infection. Infection can be bacterial, it can be tubercular, it can be fungal, and here is a cavity you can see. So it was identified fungal cavity, and fungal cavity led to, then antifungal treatment was given. Now you can see there is cavity, but still there is a ground glass halo that shows it is responding. And in day 54 you can see this cavity is replaced by the solid form. It does mean the patient is recovering and it has recovered from that particular infection. But patient is still on oxygen, patient is unable to walk, and what to do now? Lot of reticulation you can see. What to do? So with proper type of specialized rehabilitation which has been developed in RHL, as I was sharing that RHL was born almost coinciding with the COVID era. So we established RHL Rehabilitation Center, and that she was on 3 to 5 liter oxygen, but at the time of discharge she was off oxygen and was able to walk 300 meters in 6 minutes. Another patient, 35-year lady, you can see the extensive haziness, and there is consolidation also. These are ground glass areas, but this is a patch of consolidation. Day 28, it shows resolving phases, but still reticulation and fibrosis is still there. Now and it is, you can see subpleural shadows with sparing of periphery. She was transferred from some other hospital, and there she was prescribed lot of methylprednisolone, 1 gram methylprednisolone almost daily for a week, and result was she had severe myopathy, unable to move. Gradually steroids were tapered, and she was enrolled in the rehabilitation program. High dose steroid leads to myopathy, it can lead to neuromuscular weakness, heart failure. In 1 month time she was able to walk. You can see with whole upper she is unable to move her limbs. Now she has started moving with assistance. And at the time of discharge, she was able to climb even the stairs. Yet another patient with cavitatory lesion. You can see lot of cavitatory lesion, and again fungus was identified as culprit, and she was given, you can see when she was transferred to our center, her illness was 34 days, a big cavity with on day 73 after proper antifungal treatment, you can see even the cavity disappeared and she was discharged. And just 10-15 days back she came, she was absolutely normal कि साहब खेत में जाके काम कर रही हूँ अभी तो. Yet another patient, you can see, वो अपने जो ट्रेडिशनली कहते हैं ना 25/25 स्कोर, remained on ventilator for couple of days, and when he, and then the complication, you can see severe pneumomediastinum. What to do? Any suggestion? Pigtail catheter was put, and with pigtail catheter he improved, and on day 20 you can see that though there is lot of ground glass opacities and fibrotic bands, but he improved a little remarkably. And the last case, a case 38-year engineer got severe COVID. He was on 12 liter per minute oxygen for 2 months almost. Now what to do? Again he was enrolled in the program, and the first step which is done in enrolling in the program is rule out these 4 things. Because of high tendency of clotting, we should rule out this thing: heart failure with echo, infection of fungus and TB, and then the lung punctures in form of pneumomediastinum or pneumothorax. So 2 weeks of IPD rehabilitation, pirfenidone was given, methylprednisolone 4 mg, oxygen was gradually reduced and it was reduced to half liter and then stopped. He went home. He said that I will drive my own car and go. So he sent this photograph. So friends, what happens? What is the basic thing? Basic thing is that when a patient gets sick, then it results into activity less. When he performs activity less, then his fitness declines. When fitness declines, dyspnea is more. So this is a vicious cycle. Dyspnea more means activity less means fitness reduced means more dyspnea, and it leads to bad trap, not bad, BED, वो खाट पे ही बंद के रह गया. That is a trap. So this is the trap. It happens starting from stamina of 100 meter, then 80 meter, 50 meter, 10 meter, and bed bound. So that is a usual cycle. How to break this cycle? That is the issue. And if we move reverse, if this bed bound patient performs supervised exercise program with rehabilitation, then with this exercise there will be better fitness will be better, then dyspnea will be less, and so it will move in reverse direction and patient will come out of this vicious cycle to enjoy normal life. So at which point we should break, that is a matter of skill. And our team, अभी हैं क्या आपने अरुण या नहीं, rehabilitation team के कोई सदस्य नहीं. Okay, so we are having excellent team of 3 rehab persons I wanted to see. Okay, so in the conclusion, friends, we can see that make diagnosis of patient in respiratory symptom and identify clot, heart failure, infection, fungus, TB, lung puncture and rehabilitation. Thank you very much.
In fact, very nice presentation, sir. You are expert in making the subject very simple. Now, house is open for questions.
Any query or curiosity, but don't ask difficult questions कि ये कैसे किया. Okay, thank you very much.
Thank you, sir.
And now may I ask to Dr. Pawan Mehta to present their topic.
Dr. Pawan Mehta will be talking about arrhythmias, diagnosis, treatment, and optimization at primary care. I request sir to please come to the stage.
Full slide. इधर तो फुल करूँगा ना सर, उधर कट के आता है. अच्छा, आप कहें तो मैं करता हूँ. Good morning, respected seniors and dear friends. I'll talk on arrhythmias, diagnosis, treatment, and optimization at primary care. So this is the normal impulse conduction we have already seen yesterday, and the normal heart rate is around 60 to 100. To understand arrhythmia, first we have to understand what is the mechanism of the cardiac action potential. And the cardiac action potential has 4 phases. That is the phase 0, that is the depolarization phase, and phase 1, phase 2, phase 3, and pacemaker cells, that is the SA node cells, have phase 4. So these are the repolarization phases. And every stage has different molecules which delineate the depolarization and repolarization process. So this is the pacemaker site which have phase 4 in the action potential. It is present only in the pacemaker cells, that is in the SA node. So what are cardiac arrhythmias? An abnormality of the cardiac rhythm, and it may cause sudden death, syncope, heart failure, dizziness, palpitations, or maybe asymptomatic. There are 2 main types of arrhythmias, bradyarrhythmias and tachyarrhythmias. When the heart rate is less than 60, it is bradyarrhythmias, and when the heart rate is more than 100, it is tachyarrhythmias. So what is the mechanism of bradyarrhythmias? It may be because of abnormally slow automaticity, and maybe because of abnormal conduction within AV node and below distal AV conduction system. The tachyarrhythmias may be caused by accelerated automaticity, triggered activity, or re-entry or circus movements. Accelerated automaticity can occur in virtually all cardiac tissues because they are more excitable and may initiate arrhythmias. The examples are sinus tachycardia, escape rhythms, and accelerated AV junctional rhythms. The triggered activity can lead to after depolarization, that is early after depolarization and delayed after depolarization. For example, drug-induced, that is digoxin-induced tachycardias and tachycardias associated with long QT syndrome comes under triggered activity. Catecholamines, that is stress-induced electrolyte imbalance, can also cause this triggered activity and leads to arrhythmias. Some forms of arrhythmias like AV reentrant tachycardia or some kind of atrial flutter can be because of the re-entry or the circus movement because of the scarred myocardium. The majority of regular paroxysmal tachycardias, what we have seen in our practice, that is AVNRT is a kind of re-entrant tachycardias. This is the normal pathway, this is the fast pathway, and this is the slow fast pathway. In the re-entrant tachycardia, what happens, that is the refractory period of this increases, and the conduction goes from the fast to the slow, and this forms a re-entrant tachycardia. This leads to the So first of all, we will see what are sinus arrhythmias. It is a condition in which the heart rate varies with breathing, and it is a normal phenomena. As we have seen, during inspiration, the heart rate is more, the RR interval is less, and during expiration, the heart rate decreases. It is a normal phenomena and no treatment required for this condition. Supraventricular tachycardias are the tachycardias which arise from the atria or AV junction. And the conduction through the His-Purkinje system is normal, so the QRS is normal in duration. The kinds of various supraventricular tachycardia are sinus tachycardia, AV re-entrant tachycardia, AVRT, atrial fibrillation, flutter, paroxysmal atrial tachycardia. In pulmonary patients, this is the hallmark. Multifocal atrial tachycardia is present in pulmonary patients. And we have junctional tachycardias also. So sinus tachycardia is a condition in which the heart rate is around 100 to 160. It may cause weakness, fatigue, dizziness, or palpitation. And it is usually occurs under stress or exercise, strong emotions, fever, dehydration, thyrotoxicosis, anemia, and heart failure. So we have to treat the cause, and if necessary, beta blockers can be used to slow down the sinus rate, for example, in hyperthyroidism. This is an example of sinus tachycardia. The heart rate is around 150, but the rhythm is normal. And when beta blocker was given, the sinus tachycardia is converted into normal heart rate. The premature atrial contractions are common and may occur when a stimulant is when a patient consumes a lot of coffee, tea, alcohol, cigarette medications, and temporary treatment is rarely necessary. It can be associated with hypokalemia also, and when the patient takes steroid inhalers, then atrial premature contractions can be present. So this P wave is normal, this P wave is normal, and this P is coming with the abnormal morphology. It comes earlier than the normal P wave. So this is the abnormal P wave which conducts, and it has a pause, but it is not a fully compensatory pause because the PP interval is less than twice the normal PP interval. Paroxysmal supraventricular tachycardias includes AV nodal reentrant tachycardia. It is the most common tachycardia seen in our practice, and it may lead to weakness, fatigue, dizziness, fainting, or palpitation if the heart rate becomes too fast. It is of two types, typical AVNRT and atypical AVNRT. And this is the ECG. The usual heart rate is between 140 to 250. The QRS complex is normal in duration, but if we have seen, this is the normal PQRS, and this peak comes earlier. Then it is initiate the tachycardia. So what is the treatment? First, we have to treat the cause. If the patients have electrolyte imbalance or any medications if the patient is taking which leads to arrhythmia, we have to treat the cause. Then AVRT. AVRT is atrioventricular reciprocating tachycardia. It includes an abnormal conduction from the ventricles back to the atria. It has an accessory pathway or the bypass tract, which leads to conduction from atria to ventricles and leads to tachycardia. So what is the management? Acute management, if the patient is hemodynamically unstable, we have to do emergency cardioversion. That is, DC cardioversion should be given, 150 joule DC cardioversion should be given. If the patient is hemodynamically stable, we can try for vagal maneuvers or carotid massage can be done successfully. If the patient does not respond, we have to give adenosine, and adenosine has short half-life, that is of 6 seconds. So we have to give in the central cubital vein and push the saline immediately. If the patient does not respond to adenosine, we can try for verapamil, and diltiazem or beta blocker can be tried. And long-term management includes radiofrequency ablation, and medical therapy can be continued for a long time. The WPW syndrome, we have already seen that it has an abnormal pathway that leads to short PR interval with delta waves, and it leads to AVRT, atrioventricular reciprocating tachycardia. The treatment includes drugs like flecainide, amiodarone or disopromide. Digoxin and verapamil are contraindicated in this form of tachycardia. Atrial flutter, as we have seen, it has a heart rate of 200 to 350, and it has a classical sawtooth pattern is there. What is the treatment of the atrial flutter? We have to immediately cardiovert the patient, if the patient has an atrial flutter of more than 1 to 2 days, then first we have to anticoagulate the patient for 4 weeks prior to cardioversion. And recurrent paroxysms can be prevented by class 1C and class 1-3 drugs. If the patient has recurrent atrial flutter on medication, then we have to go for radiofrequency catheter ablation or surgery can be tried. This is an ECG of atrial flutter which have classical sawtooth pattern, and it can be present with variable AV conduction block. Atrial fibrillation, as we have seen, it has an irregular heart rate with normal QRS or maybe wide QRS. It is usually associated with hyperthyroidism, CAD, valvular heart disease, or hypertension. This is an ECG of an atrial fibrillation which have irregular heart rate. So if the patient presents with atrial fibrillation, then we have to first anticoagulate the patient at least for 4 weeks, then try for anticoagulation. We can go for rhythm control or rate control. The choice depends on whether the patient can tolerate the arrhythmias or not, whether anticoagulation is required before considering elective cardioversion, and whether spontaneous cardioversion is likely. The patient should be anticoagulated 4 weeks before cardioversion, or if we want to cardiovert, then transesophageal echocardiography can be done to look whether atrial thrombus is present or not. Anticoagulation should be should be given for long time, and Child's-Weiss score should be done to assess whether to start the anticoagulation or not, and Hasbled score should be seen to see whether if there are chances of bleeding are more or not. Rhythm control can be tried with antiarrhythmic drugs, and rate control can be done by digoxin, beta blockers, or calcium channel blockers like verapamil or dilzam can be given. The target INR should be kept between 2 to 3. Ventricular tachyarrhythmias can be premature ventricular beat or couplets in the form of bigeminy, trigeminy. This is a classical example of a VT, which with the QRS complex is more than 0.14 second. There is broad QRS tachycardia. If the patient is hemodynamically unstable, then we have to immediately cardiovert the patient by giving DC shock. If the patient is hemodynamically stable, we can try for class 1 and class 3 drugs. That is, lignocaine can be given 50 to 100 milligram IV over 5 minutes, followed by lignocaine infusion. Cardron can be tried 150 milligram IV bolus over 10 minutes, followed by 1 milligram per kilogram body weight for 6 hours, and then after 6 hours, 0.5 milligram per kilogram body weight for rest 18 hours. And we have to identify the cause, whether it may be ischemic VT, or it is because of electrolyte imbalance, or it is because of any drugs which can prolong the QT. For example, quinolones, antifungal drugs, prokinetic drugs, they prolong the QT and may cause arrhythmias. This is an example of ventricular fibrillation. We have this baseline, this Bizarre form QRS complex, and immediately cardioversion should be given, because asynchronous cardioversion should be given. We should not even wait for the defibrillator for synchronization. And we have to identify the cause. If the patient have myocardial infarction, severe metabolic disturbance, should be immediately treated. And for long-term management, AICD should be done. Automated implantable cardiac defibrillator should be given. This is a form of AICD in which we kept a generator here, and through the subclavian vein we put a lead in the right atrium and the right ventricle. It has dual function. It can pace in case of bradycardia, and during the time of tachycardia, it shocks. Torsades de pointes is a type of tachycardia. It may be congenital or associated with electrolyte imbalance, or maybe associated with drugs, for example, tricyclic antidepressants, or any drugs which can prolong the QT. For example, here is a patient who is taking sotalol. This is the beta blocker, and it prolongs the QT. The QT interval is very much prolonged here, and so this prolonged QT initiates the tachycardia. So the treatment is to stop any drug which is causing the QT prolongation. And the treatment includes correction of electrolyte imbalance. Magnesium sulfate should be given 8 milligram over 10 to 15 minutes, and isoprene infusion can be tried. And in cases of congenital long QT interval, beta blocker should be given. This is a premature ventricular contraction. It is a single premature ventricular contraction. When it is more than 3, it is called as ventricular tachycardia. It can be sustained or non-sustained. Sinus bradycardia, when the heart rate is less than 60. During sleep, it can go as low as 40. the cause is hypothermia, hypothyroidism, cholestatic jaundice, raised ICT. We have to find out the cause and treat the cause. This is the heart rate is regular, but sinus bradycardia is there. Heart rate is less than 60 beats per minute. Sick sinus syndrome, we have tachybrady phenomena. So sometimes patient is having tachycardia, sometimes the patient is having bradycardia. So for bradycardia, we have to pace the patient, so permanent pacemaker implantation should be done. And for tachycardia, we have to control the heart rate by giving antiarrhythmic drugs. And it is usually associated with thromboembolic phenomena, so anticoagulation should be given unless contraindicated. First degree AV block, if it is asymptomatic, and then we have to do nothing for this. If any drug, for example, digoxin is causing, or it may be associated with acute rheumatic fever, then we have to treat the cause. Second degree AV block we have already seen yesterday, that is of two types, of which type 1 and type 2. If the patient is symptomatic, if the patient is having dizziness, and so we have to treat the cause, and we have to treat the patient by implanting permanent pacemaker. So this is the type of type 1 the Vankebeck phenomena. This is the type 2 second degree AV block. In third degree AV block, then there is complete AV dissociation. So we have to treat the patient by putting permanent pacemaker. So management of arrhythmias can be pharmacological therapy, cardioversion, pacemaker therapy. Surgical therapy includes aneurysmal excision if there is LV aneurysm, interventional therapy, radiofrequency ablation. So different drugs act on different levels at the action potential. So class 1 drugs act on the sodium channels at the phase 0. Class 2 drug, that is, it includes beta blockers, it acts on the plateau phase, that is the phase 2. Class 3 drugs includes cardron, sotalol, it acts on the potassium channels and it inhibits the phase 3. And class 4 drugs includes calcium channel blockers. So this is the classification of the antiarrhythmic drugs. Class 1A includes quinidine, procainamide, disopyramide. Class 1B includes lignocaine, and class 1C includes flecainide, anakinide. It should not be used in patients with structural heart disease. Class 2 includes beta-adrenergic blockers like propranolol, esmolol. And class 3 is potassium channel blockers, cardron, sotalol, ibutylide. And class 4 is calcium channel blockers. They includes verapamil and diltiazem. Thank you.
Dr. Govind Sharma. I call to Dr. Govind Sharma.
Thank you.
There's a slight change on popular demand. There's a change in topic. Dr. Shitu Singh. Abhi nahi. Next talk will be delivered by Dr. Govind Sharma. The topic will be newer pharmacotherapy in heart failure, how and what to adapt in clinical practice. I request Dr. Govind to please come to the stage. Paper just okay. Also, we are circulating one sheet of paper. We request you to write down your names for the certificates. The certificates will be given at the end of the conference. Please write your name in capital letters.
किस नाम से आपका हार्ट फेलियर हाँ ये पॉइंट चेंज किससे होगा चेंज इसी से होगा ना दिस इज बेटर ओके ओके थैंक यू इसको थोड़ा ऊपर कर सकते हैं नहीं रहेगा ठीक है सो good morning to all the chairperson, Dr. Bharat Bhushan Sharma, who was my mentor during my post-MD days. And good morning to all the delegates. I would like to discuss with the heart failure, which is more and more the patient we treat with the CAD, more and more we are accumulating the heart failure patients. So it is estimated that by the year 2030, we will be having every fourth person beyond the age of 40 will be affected by the heart failure. So this is the epidemic which is rising. So I would like to highlight few points, as all of you know the basic treatment for the heart failure. But here I would like to highlight the new changes which was published in 2022 by the ACC and ESCA consensus statement. So there are slight changes in the classification of heart failure, and there are also new treatment modalities which has changed the treatment at such an extent that heart failure waiting list in the Western world has been revised. Many of the patients who were in the waiting list for the heart failure now are asymptomatic, and they have been taken out of this heart failure list. So last 5 years, they were revolutionizing in this heart failure treatment. So first of all, there are slight changes in the heart failure classification. Previously, we used to know that there were only two classes of heart failure with the reduced ejection fraction, and another was heart failure with preserved ejection fraction. Now there are two another classes which has been accepted by both the American and European classifications. The first is heart failure with mid-range ejection fraction, which is 41 to 49% of ejection fraction on the 2D echo. Another is the patient class who previously was in the heart failure preserved ejection fraction or reduced ejection fraction class, but now the EF has improved to more than 50%. The serial assessment of the heart failure patient is also important because this will have the importance in the follow-up treatment of the heart failure patient. Initial classification we can classify in any of the class of these three mentioned classes, but on serial follow-up, many of the patients improve their ejection fraction, so they are reclassified as the heart failure with the improved ejection fraction, but that do not change the treatment of this patient. They should be always treated as the heart failure with the reduced ejection fraction to prevent the recurrence of their failure again. So this is very important. If a patient with a heart failure, you start a treatment, and if their heart ejection fraction improve, you don't change the treatment. You keep on them all the previously started medications. So this is the latest treatment recommendation from the authorities and the heart failure patients. Previously, we used to start the AC inhibitor and ARBs as a first-line treatment in the heart failure patient, but now they have recommended all the patients who can tolerate the ARNIs should be started with the ARNIs at the first step, along with the beta blocker and mineralocorticoid receptor antagonist. And at the 2 to 3 weeks interval, they should be optimized in the doses. And if still symptomatic, or if the patient is overweight or diabetic, then SGLT2 inhibitors are the class which should be added as add-on therapy in these kind of patients. Vericiguat and omecamtiv, these are research drugs, but I have mentioned because these are upcoming therapies in the resistant heart failure patient. I will not discuss in detail because these are still at the institutional level, not in the routinely used in the clinical practice. So another class which is newly highlighted in this classification is heart failure with mid-range ejection fraction, which is 41 to 49%. Here also the class 1 treatment, class 1 recommendation is for diuretics. Apart from that, SGLT2 inhibitor, these are the new class of drug which I will discuss in further slide also, how to start them and how to optimize with those drugs. So class 2A is, it should be used, and class 2B means that it can be used if patient is tolerating these drugs. So SGLT2 inhibitors are the drugs which should be used in these kind of patients. And apart from that, AC inhibitor, ARNIs, ARBs, mineralocorticoid receptor antagonist, these are, if patient tolerate, they should be given to the patient. Now, as I discussed previously in the slide, heart failure with improved ejection fraction patient should be continued on the goal-directed medical therapy, which was started at the beginning when patient had low ejection fraction. If you withdraw that therapy on the basis that ejection fraction has improved, there are high chances that patient will land up again in the heart failure, and the ejection fraction comes back to the initial stage. So now there is slight changes in the, previously there was only one therapy which was recommended in the heart failure with preserved ejection fraction were diuretic, and apart from that, treatment of this comorbidities like diabetes and hypertension. But recent trial have shown that apart from that, SGLT2 inhibitor has shown promising result, and it has reduced the mortality and hospitalization rate in the patient with heart failure preserved ejection fraction. This is very beneficial thing. Prior to this, we did not have any medication apart from diuretics for the heart failure preserved ejection fraction patients. And apart from that, ARNI MRA has 2B recommendation, so it can be used if required. So first of all, I will discuss about the SGLT2 inhibitor. Before that, how it works, let's have a quick view. That as we all know, the filtered glucose is reabsorbed in loop Fenley and proximal convoluted tube with the SGLT2 and SGLT1 receptor. The most 90% of absorption is being taken by the SGLT2 receptor. So, and this leads to the high blood sugar levels in the diabetic patient because of high insulin level. But SGLT2 receptor blocker leads to the blockage of this reabsorption of the filtered glucose, and along with that, sodium is also excreted in the same amount as the glucose is being excreted. So ultimately, it leads to the contraction of the plasma volume and reduce the toxic effect of the glucose, which are exerted by the oxidative stress and many other pathological phenomena. So all we know that it leads to the cardiac fibrosis, increased chances of stiffness of heart, increased stiffness of the vessels. So these are the indirect effect of the increased blood glucose level. Apart from that, reducing the blood glucose level, it also leads to lipolysis, which help in the body fat reduction, and along with that, the patient the insulin requirement is also reduced. So this is the few mechanism by these drugs act, and these are the 3 drugs which are available in this class. First is canagliflozin, dapagliflozin, and empagliflozin. So all the 3 drugs are available in the market. The preferred drug are dapagliflozin and empagliflozin because these have strong evidence in the heart failure patients. And below the 45 eGFR, there needs a dose adjustment in the dapagliflozin and canagliflozin, but no dose modification is required in the empagliflozin. So how these drugs should be initiated? So if the patient is taking 10 milligram of enalapril or less than 16 milligram of valsartan, those patients should be started on the 50 milligram twice a day of this ARNIs, which is sacubitril valsartan. And if a patient is taking more than these doses, then they can easily start it with the 100 milligram twice a day doses. Sorry. So next drug is sacubitril valsartan. This is the therapy which have class 1 implication in heart failure with the reduced ejection fraction, and apart from that, it is also being used in the heart failure with the preserved ejection fraction. So how does it act? Valsartan is, as we all know, this is typical ARB receptor and angiotensin receptor blocker which act on AT1 receptor, and sacubitril is the new thing which is part of this drug. It inhibits the neprilysin. Neprilysin is the degrading enzyme of natriuretic peptide which are secreted by the heart in response to the increased filling pressures. So this natriuretic peptide have a lot of beneficial effect on the kidneys and intravascular volumes. It induces the vasodilation, decreases the sympathetic nervous system activity, increases the parasympathetic nervous system activity. It has reduces the cardiac fibrosis, and chances of arrhythmia are lesser with this therapy. So as I told, this is a class 1 therapy recommended prior to initiation this AC inhibitor and ARB. If patient do not tolerate these therapy, then patient should be started with the AC inhibitor and ARB. So these are the doses which should be given to the patient. Initially, if patient does not have any contraindication or requiring any precaution to reduce the dose, then it should be started with the 50 milligram BD doses. And if patient is having renal compromise or moderate hepatic compromise or elderly patient, then the doses should be half of the tablet of 50 milligram twice a day. Then you can optimize the tablet therapy with the 2 weeks interval. Every time you must monitor the patient's renal function test and blood pressure. If there is any increase in the more than 30% rise in the serum creatinine, or his patient is having raised potassium, then you might need to reduce the dose of ARNIs, or you have to stop the medication and switch to the ACE inhibitor and ARBs. So these are the studies, pioneer heart failure transition, which provided the evidence in favor of this ARNI, which is new therapy. And apart from that, the recently published trial, which is Paragon heart failure, this has shown promising result in the patient with heart failure preserved ejection fraction. It has shown the reduction in the mortality and hospitalization rate once started on the ARNI therapy. Apart from that, if patient is on the beta blockers and the heart rate is still not controlled, and you want to increase the beta blocker doses, but patient is not tolerating, then the ivabradine comes in the picture, and you can start with this therapy to control the heart rate. This is also a class 2A recommendation, and this has shown the benefit in mortality and hospitalization rate. This is this is new therapies, soluble guanyl cyclase stimulator, which is still in the research level. This have class 2B recommendation. Thank you. So,
thank you, Dr. Sharma. It's a very nice presentation. Any questions from the audience?
Yeah, please. Sorry. Wait.
Recently, you started with dapagliflozin as on what dose you prefer the dose of dapagliflozin?
So initially we can start with the 10 milligram doses. If if the patient is diabetic, then it will help in the sugar control also. And you can start with the 10 milligram. If there is a renal compromise, then you prefer with the empagliflozin, better with the empagliflozins.
Thank you.
Yes, sir. No, sir. There is no chances of hypoglycemia with this drug. That is the benefit of this drug. This drug in the non-diabetic patient and who are overweight, this is also a very promising drug. This helps in body weight reduction, so it ultimately leads to the improved exercise tolerance and otherwise also indirect effect on the heart failure patients. Thank you.
Thank you, Dr. Sharma. Next question.
Thank you, Dr. Govind. Thank you, respected chairpersons. We'll now be conducting the first round of the quiz. We'll be displaying a QR code. I request you all to please scan it so that we can start with the quiz. It will be a 10-minute quiz. If any of you face any issues, our team is right there. They can help you with it.
Please scan this QR code and the Google forms for the quiz will come. You will get 10 minutes.
Has everyone managed to scan the QR code, or anybody is facing any difficulty? You can please raise your hand. The winner of the final round will get an iPad.
Dr. Ranu wants to take part. You are most welcome, Dr. Ranu, to participate in the quiz and win an iPad. 7 minutes left. Just quickly hurry. Just 4.5 minutes left.
The result for the quiz will be declared before the final round, after the sessions are completed. 2 more minutes, last 2 minutes. Okay. Last 1 minute. You have to submit your responses before the completion of this last 1 minute.
If you don't submit, the quiz will shut down and your responses will not be saved. So please submit before this completes, then we will be closing the quiz online. So hurry up, become Cinderellas and submit prior to it becoming 0-0.
Please submit your responses. Time's up. So we start with our next sessions. I would invite our chairpersons to the stage, please. Dr. P.R. Gupta, sir. Dr. Anula Sisodia, ma'am. Dr. Nirupam Chakrabarti. If anybody has not written their name in the list for the certificates, please, you can contact Mr. Varun.
Hello.
The next talk for the day will be cardiac evaluation for non-cardiac surgery. The talk will be delivered by Dr. Rakesh Bhargav. Dr. Rakesh Bhargav is the HOD and Chief Cardiac Anesthetist of the Heart Center at Rajasthan Hospital. He has excellent exposure in the entire spectrum of adult and pediatric congenital cardiac surgeries and cath lab procedures. I request sir to come to the stage.
इसे डाउन करना इसकी जो good afternoon all. Today I am presenting cardiac evaluation for non-cardiac surgery. As all of known, the patient undergoing major non-cardiac surgery and vascular surgery are at risk of major adverse cardiac events defined as death and MI, which are the common cause of perioperative morbidity and mortality. It is estimated that cardiovascular complications are responsible for roughly 1/2 of the mortality of the non-cardiac surgery and 1 to 5% of the vascular surgeries. The purpose of perioperative evaluation is to identify the most appropriate investigation and patient condition optimization, provide risk profile to the patient care team, like surgeons, anesthetists, and the intensivists, to give the surgical clearance. A thorough perioperative evaluation and appropriate risk stratification is necessary to minimize the perioperative complications to reduce the morbidity and mortality. The initial history, physical examination and ECG assessment should be focused on identification of potential serious cardiac disorder like CAD, heart failure, symptomatic arrhythmias, history of pacemaker or ICD, orthostatic intolerance or anemia, cardiac disorder. And also we have to rule out their severity, stability and prior treatment. Other factors they help determine the cardiac risk include the timing of surgery, type of surgery, physical capacity, age and the other morbid conditions. Different category of non-cardiac procedure depends on the availability of the time for the evaluation. An emergency procedure, there is no time for evaluation or limited time for clinical evaluation, less than 6 hours. An urgent procedure, there may be time for limited clinical evaluation, typically between 6 to 24 hours. A time-sensitive procedures, in which delay of the 1 to 6 weeks to allow for an evaluation of significant change in management will negatively affect the outcomes. Most of oncological surgery comes in these categories. An elective procedure could be delayed for up to 1 year. Surgery specific. We divided the surgery into 3 categories based on their risk of mortality. High risk surgery, where risk of mortality is the more than 5%, moderate risk when there is risk of mortality 1 to 4%, low risk surgery less than 1%. In high risk surgery, we include the emergency surgery, especially in elderly, cardiac surgery, major thoracic surgeries, aortic surgeries, peripheral artery disease, and prolonged surgery, anticipated large fluid shift or blood loss. Moderate risk surgery in orthopedic surgery, urological surgery, uncomplicated abdominal surgery, and the complicated head and neck surgeries. Low risk surgery, where risk of mortality is less than 1%, endoscopic, bronchoscopic, hysteroscopy, cystoscopy, skin and soft tissue, breast, ophthalmologic surgeries. There are few clinical predictors for increased perioperative cardiovascular risk of MI, heart failure and death. We divide into 3 categories: major, intermediate and minor. Major clinical predictors are unstable coronary syndrome, decompensated heart failure, significant arrhythmias and severe valvular disease. In intermediate, there is mild angina, old MI, compensated heart failure, diabetes mellitus, particularly insulin dependent, renal insufficiency, obesity, anemias. The minor clinical predictors are advanced AS, non-sinus rhythm, low physical capacity, no history of stroke, uncontrolled hypertension, and abnormal ECG like LVS, LVB, ST changes. Perioperative cardiac morbidity risk calculation. There on the basis of revised cardiac risk index, we categorize the procedure on the low risk procedure and the elevated risk procedure. Low risk procedures are when combined surgical and patient characteristic predict a risk of major adverse cardiac events less than 1%. An elevated risk procedure when the risk of major adverse cardiac events are more than 1%. RCRI 0 to 1 risk factor, that procedures come under the low risk of MASH, and RCRI when 2 or more risk factor, elevated risk of MASH. Revised cardiac risk index, there is 6 independent factor, major independent factor which determine the complications. Patient has the undergoing high risk surgery or history of ischemic heart disease, history of heart failures, history of CVA, insulin dependence, diabetes mellitus, or serious creatinine more than 2 mg per deciliter. Rate of cardiac death, non-fatal MI, non-fatal cardiac arrest according to the number of predictors. If there is no risk factor, chances of above complications are 0.4%. If there is one risk factor, above complications can be occur in 1%, and more than 2 risk factors, then 2.4, and more than 3, then risk is more than 5.54%. Functional status assessment. Functional capacity is often expressed in terms of metabolic equivalent, where one MET is the resting or basal oxygen consumption. So we can divide the patient into 3 categories: excellent, moderate physical activity, physical status, or poor physical status. Excellent when activity is more than 7 MET, moderate when activity is 4 to 7 MET, and poor when less than 4 MET. So moderate activity just like a cycling, climbing, or the flight of stair, golf, walking 4 miles per hour. Poor activities, sleeping, daily activities, walking, 2 miles per hour and writings. This is the algorithm, for the perioperative cardiac risk assessment. Step 1, when patient came to us, first of all, in first step, stratify the risk. Emergency, if there is need of emergency surgery, clinical assessment, do clinical assessment and proceed for surgery. If surgery is non-elective surgery but not emergency surgery, is proceed to step 2. Step 2, if patient has the acute coronary event, treat according to goal-directed therapy. If patient does not have ACS, proceed to the step 3. Low risk with MACE less than 1%, proceed to the surgery with no further testing. If there is elevated risk with MACE greater than 1%, proceed to step 4. In step 4, there is moderate to excellent exercise capacity, MAT more than 4, then proceed to surgery with no testing. If there is poor functional capacity less than 4, or there is physical capacity unknown, further testing will impact perioperative management and outcomes. Proceed to the step 5. In step 5, we do the cardiac stress testing. If cardiac stress testing is normal, proceed to the surgery with no further testing. If cardiac test is show the abnormal, then perform the coronary angiography and revascularization. Proceed to the surgery according to the established guideline in patient with revascularization or non-invasive surgical alternative. Perioperative cardiac testing. ECG is generally not recommended for low risk procedures, but if patient has history of CAD, peripheral artery disease, significant arrhythmia or CVA, then we should do the ECG. LV functions, 2D echo. If patient has the history of dyspnea, heart failure and the reassessment of the function, clinically stable patient, if it was not done more than 1 year ago. Exercise testing in high risk surgery and when functional capacity is less than 4. Pharmacological testing, dovitamin stress echo or myocardial perfusion imaging only if change further management in poor functional capacity less than 4 MAT or schedule for elevated risk surgery. Coronary angiography, same indication is the same as non-operative indications. BNP and anti-probe BNP used for diagnosis the heart failure or assessing the optimism of heart failure patients. Troponin in case of post-op MI, cardiopulmonary exercise testing. Myocardial injury after the non-cardiac surgery means is defined as the myocardial injury owing to ischemia within 30 days after the non-cardiac surgery. The mechanism of means in supply demand mismatch from CAD and ischemia secondary to obstructive CAD. Means is important marker of the mortality after the non-cardiac surgery. 30-day mortality increase with increased value of post-operative high sensitivity cardiac troponin T. Approximately 8% patients experience means after the non-cardiac surgery. This is the indication elective non-cardiac surgery in patient prior PCI or CABG. Elective non-cardiac surgery in who dual antiplatelet therapy has to be discontinued prior to the surgery. For balloon angioplasty, it should be do after the 14 days. For bare metal stent implantation after 30 days, or we can do surgery after the drug-eluting stent 3 to 6 months. And for post-CABG, we can do the non-cardiac surgery after the 4 to 6 weeks. Highest risk of stent thrombosis is in the first 4 to 6 weeks after the stent implantation. Algorithm for the recommendation. If a patient came to for non-cardiac surgery, if patient had the history of PCI, in PCI, if patient had bare metal stent, if we are doing surgery within 30 days, if possible, we can delay the surgery. If we cannot delay, then proceed to surgery. If we are doing surgery within more than 30 days after, proceed to surgery. Surgery within 3 months, if we are doing surgery within 3 months, if possible, we could delay, then we should delay the surgery. If we could not delay the surgery, then we should proceed for the surgery. If we are doing surgery within 3 to 6 months, proceed if risk of the delay in the greater than the risk of thrombosis. Surgery after the 6 months, proceed to the surgery. Cardiac medications, antiplatelet therapy, dual antiplatelet therapy has to be discontinued for urgent or no emergency surgery. Aspirin should be continued if possible, and dual antiplatelet therapy should be restarted within 24 hours of the surgery if possible. Anticoagulation therapy, low bleeding risk surgery, anticoagulation therapy can be continued. Patients with AF who are anticoagulant therapy with increased risk of bleeding, holding vitamin K antagonist therapy for 1 week is acceptable. In patients who have high risk of thromboembolism, just like a prior history of stroke or underwent mechanical valves, bridging anticoagulation is preferred once VK withheld. DTI, direct thrombin inhibitor like rivaroxaban or apixaban. If patient has the normal renal function, discontinue 48 to 78 before the surgery. If patient has the mild impaired renal function without 4 to 5 days prior to the surgery, severe renal insufficiency without more than 7 days. Beta blocker therapy, patient with moderate to high risk myocardial ischemia, it is reasonable to begin perioperative beta blocker if not contraindicated. Statins, perioperative statin therapy should be continued if patient taking them. Calcium channel blocker is not recommended for the cardiac protection in the non-cardiac surgery. AC inhibitor, without AC inhibitor and ARB perioperatively, it is reasonable to restart as soon as possible. NTG, intravenous NTG prophylactically to prevent myocardial ischemia is ineffective. Summary. Cardiac evaluation for non-cardiac surgery primarily depend on the 4 factors: timing of surgery, type of surgery, physical status or functional capacity. As per MAT concept, when patient can be climbed to flight or can be fully managed housework by own self, fit for surgery. Risk of mass, if less than 1% low risk, combined surgical and patient specific risk of as per revised cardiac risk index. If more than 1%, there is elevated risk. So, if time of surgery we are doing, there is no time to evaluation, we can do proceed for surgery, emergency surgery. If there is time for elective surgery, combined risk for surgery based on type of surgery and the mass. If there is intermediate or low risk, proceed for surgery. If surgery is high risk, then physical capacity. If physical capacity is more than 4 MET, proceed for the surgery. If physical capacity is less than 4 MET or unknown, cardiac stress testing is advised, and if cardiac stress testing is normal, proceed for the surgery. If positive, coronary angiography and revascularization or go direct to medical therapy. Proceed for surgery and as per guideline or non-invasive alternative for the surgery. Thank you.
Thank you. Any questions? 1 or 2? Okay, if there is none, thank you very much.
Thank you, sir.
I would like to invite our next speaker. Our next speaker is Dr. Budhaditya Chakravarti. He is the director and head of cardiothoracic and vascular surgery at Rajasthan Hospital, Jaipur. He is one of the 2 primary surgeons who has done the first successful heart transplant in Rajasthan. Dr. Chakravarti is a dynamic and talented cardiothoracic and vascular surgeon. Apart from basic cardiac and thoracic procedures, he has a rich experience in performing advanced off-pump CABG surgeries like Lima-Rima Y technique CABG, minimally invasive cardiac surgeries, complex aortic surgeries, and repair of congenital cardiac defects. Sir, I would like to request you to start the presentation.
Good afternoon, ladies and gentlemen. Thank you for this honor. It's a great privilege. I think cardiac surgery is a little out of place in this setting because we've been talking about the physician's role primarily in lung and heart management. But I feel that as gatekeepers to advanced clinical care, physicians have a very, very important role to play in the whole scheme of things. First, the patient is your first point of contact. So it's very important to understand that cardiac surgery is not as diabolic or as frightening as it's made out to be. It's a beautiful piece of art. It's a work in progress, and the results can be very, very encouraging. And the second point of contact is when patients go back after surgery to you with minor cardiac ailments. I very often hear patients calling up and saying, साहब हम तो पेरिफेरी में थे, उन्होंने बोला आपका जैसे ही देखा बाईपास हुआ है आप डॉक्टर के पास चले जाओ जिन्होंने ऑपरेशन किया है. I think that's a myth. Cardiac patients post-surgery are just as your normal patients are. If we get the basics right, then you can help them on the periphery and then guide them to us. So with those thoughts in mind, I will start my presentation. I belong to the team of RHL Heart Center. This is our erudite team, very young, enthusiastic, and joyful group of people to work with. I think it's a real blessing that I have their support. And I want to take this opportunity and thank all my colleagues, not just cardiology, cardiac surgery, anesthesia, everybody. And we play this game together every day. And just to emphasize our team CTVS, I'm joined by my associate, Dr. Nirupam, and the pillars of cardiac anesthesia, Dr. Prashant and Dr. Rakesh. Now, typical to any center, and I'm going to take this opportunity and talk a little bit about our journey into cardiac surgery in this unit and then proceed on to total arterial. I don't want to make it too technical for you to understand. But a part of our journey, in any cardiac unit, basically, if you talk about cardiac surgery per se, then this is the average distribution of cases. CABGs constitute almost about 60% of our practice. 25% roughly is about valves, which we can be replacement or repairs. And then you have the right mix of, very few cases from aortic or complex cardiac. So what exactly is complex cardiac? And I emphasize this because we, in our thoughts and in our advertisements, go ahead and say this is a center for complex cardiac surgeries. Please refer patients of complex cardiac surgeries for us. So what exactly is complex cardiac surgery? What are we exactly talking about? It can be anything like this young patient who presented with bileaflet prolapse of his mitral leaflets, severe mitral regurgitation where we did a repair of his valve, and the patient is anticoagulation free and living a normal life. Yeah. Commando procedure is one of the rarely done procedures wherein a very young female presented to us with a ruptured biological valve in acute pulmonary edema. And we had to operate on this lady in emergent conditions, actually work on 3 of her valves. We had to replace our aortic and mitral valves. We had to do a root enlargement. We had to repair the tricuspid valve. We had to recreate the entire left side of her heart using pericardium. And ultimately, the patient had to be sifted out of pulmonary edema with the help of VA ECMO. And she's leading a healthy and normal life about a year out of surgery. Endocarditis, again, dreaded combination. Most patients are in the dilemma whether they should get operated or not, was the right timing for surgery, and in that quest, we lose a lot of patients. So we are happy to report that we are a center which does successful outcomes with endocarditis. Tricuspid endocarditis, again, a very young patient from Ganganagar, drug abuser, very common in those areas. Patients don't know exactly what is the treatment. Myological valves or mechanical valves are not good options for a long time. The recommendation is repair with pericardium. And this is just to highlight, one such case which we did. If you look at the video, this will show. This is a tricuspid valve which we have recreated out of the patient's old pericardium. And you see, once we're going to test that valve, it's going to show you a beautiful, competent valve. There you see. It's all pericardium, no foreign material. So the patient does not need anticoagulation, and these valves can last him out for almost a lifetime. Sinus of Valsalva causing obstruction of the right ventricular outflow tract. Post-MI VSRs, which almost have a mortality about 50 to 70% in most settings. Total arch, our USP, we are one of the biggest aortic cases here in which we did a total replacement of the ascending aorta, the arch, all the branched neck vessels. And then I had my cardiology colleagues come in and put a stent retrogradely for the type B dissection and land that stent into the aorta. So this is cutting edge work. This is the kind of stuff we talk about in international centers, and this is what we are trying to showcase here. So there's an enormous scope of practice, not just CABGs, and there's this whole list of subjects which can fall under the gamut of complex coronary or cardiac work. And this is one of the data profiles which we had shared in our internal audit about a couple of months back. And I hope Dr. Virendra Singh will pardon me for sharing this slide. This is for international circulation. But I think this will give us an insight into the methodology or the protocol with which we are trying to build this unit up. I mean, we've had more than 100 hearts with an operative mortality less than 1%. Our average extubation times are really world beaters. We have had no re-exploration, 0 re-explorations in all these years. And our average blood transfusion requirements are less than 1 unit. So it's not just cardiac surgery about opening a patient and operating on him. It's all about developing a practice, developing a protocol. And I think I have to thank all my staff, my team members, my anesthesiologists, and the management staff to support this project. Which brings us to CABG. I'm not going to go into the guidelines of why and where patients require CABG. I'm going to just focus on 2 or 3 things. One, CABG is indicated where it is indicated, and PCI cannot be an option for CABG in all the cases. These are AHA guidelines which categorically state that if you have a patient with left main disease, CTO vessels, patients who are uncontrolled diabetics, in fact, patients who are poorly compliant on dual antiplatelets, then CABG is the procedure of choice as compared to PCI. What is total arterial CABG? Now, you very understand that, in today's practice, there is an incessant pressure on us to reinvent. If you go ahead and talk, people will say, we are doing total arterial. Why? Is it a need to market ourselves? Is it a need to make ourselves more relevant in the market? I beg to differ. I think there is a science behind it. And what is the science? When on the left you see there's an artery and there's a vein. Very clearly, the tunica media of the artery is much more thicker and muscular as compared to that of the vein. So what happens is the artery is much more elastic and distensible. The vein is distensible, it is not elastic. So what happens? Nature has created the artery to bear pressures of 100 to 120 or 140 millimeters of mercury. Whatever is the pulsatile flow, your blood pressure, the artery can bear that. But veins are not naturally designed for that pressure. So what happens is when you use a vein as a conduit, you suture one end onto the aorta and the other end to the coronary, and you use it as an arterial conduit. Over a period of time, the constant pressure pounding causes cracks in the venous intima. And wherever there's cracks, there'll be fibrin and platelet deposition. So what happens is initially the veins distend to accommodate more flow. But over a period of time, the walls keep getting thickened, and the venous caliber starts to narrow down. Ye kya hua? Okay, connection. And yeah. So what is it about the arteries that makes it special? One, the internal elastic lamina of arteries does not have fenestration. So it's a tightly packed, it's a smooth surface. The smoother the surface, the lesser the amount of thrombogenic clots. Second, there are molecules actually demonstrated inside the arterial wall, specifically the lima-rima, which are akin to heparin sulfate or TPA. Third, there are cells within the lima cells which actually release nitric oxide, and you know nitric oxide is a vasodilator. So because of all these reasons, arterial grafts are less prone to developing atherosclerosis. यहाँ पे नहीं आ रहा है. Okay, sorry for the glitch. So ultimately, what does it translate into? It translates into graft patency. And you look at those numbers, the arterial graft patency at 10 years is about 95%, whereas venous graft patency at 10 years is close to 75%. This is a beautiful paper by Renu Virmani. She is one of the great pathologists who work in the US about why a mammary artery is much better than a venous graft. And you know, histologically, how is it better endowed? So for your interest, you are welcome to read it. And as you know, in our current era, Pushpa would say, कि Pushpa झुकेगा नहीं. Surgeons can say, Lima रुकेगा नहीं. So what are the benefits of total arterial? Long-term graft patency, lesser major cardiac events, lesser readmissions, lesser future interventions and better remodeling. What is the evidence? There are two papers, one worth 12,000 patients, the other an art trial run in Australia and Europe, about 10,000 patients, which go on to demonstrate what I just said. In global statistics, well, if you look, everybody talks about total arterial grafting. But if you go ahead and Google how much percentage of practice in these countries is actually total arterial, you would be appalled. So Australia, which is the leader in total arterial, the amount of grafting in total arterial is just about 4%. US is worse off, it's 1.6. And India, well, I tried to Google stuff. There was no study published from our India. India mein to ye chalta hi hai. So I'd go ahead and present my data, and this makes a great ground for publication. Over the last 7 years or so, we've done about approximately 1,400 or so cabbages. And in spite of claiming to be a center which does total arterial, we do only about 20 to 25% of our patients as total arterial. Although, to our credit, of those 25 or 22%, 26% of patients are those with severe LV dysfunction. बंद हो गया यार फिर से. ये कुछ lose है क्या? Okay. So demography, just to give you a quick highlight, the age can be from 32 to 85, and you would ask why 85? Because sometimes it's most convenient. The beauty of total arterial grafting is that you may get away without touching the aorta. And when you are operating on an 80-year-old, your biggest concern is a stroke because the aorta is full of plaques. So, it is a beautiful surgery for that subset. You would also see in this subset, we have patients of diabetes, obesity, left main, and acute inferior MIs. But it's important to have safety first. Our data is that the global mortality for cardiac surgery for these procedures is less than 1%. So there's a pressure to conform to that. And these are conditions where we would probably not do a total arterial grafting. Arterial combinations, I'll skip this for the benefit of time. This is how it beautifully looks like. This is a lima. These are skeletonized grafts. And we have done an end-to-side anastomosis of the rima onto the lima. And this is just a work of art. I'd want to share one of the cases which I did. So this is the lima and the rima. You can see them pulsating beautifully. These are skeletonized graft. What we have done is we have taken the rima. This is one on the left side. And this is the lima. And you see we have done an end-to-side anastomosis on this. And then what we have done is essentially there's one inflow, but now we have two outflows. And using this, the two arteries, we can use this as a variety of combination. See, this is how we do it. Off-pump surgery. You see the rima has been used to graft the obtuse marginal and the PDA. And then the lima has been used to graft the diagonal and the LAD. So using two arterial conduits, you can probably end up grafting the entire heart as required. So that brings us to the end of my presentation. I will not emphasize more, but one aspect of my presentation which I would like to share, and if you could grant me 1 minute more because my presentation's conked out twice. I have a question for you. In your practice, this is not an unusual case scenario. A 65-year-old patient who's diabetic, hypertensive, EF of 35%. He's come to your clinic complaining of chest pain, shortness of breath, lightheadedness. Operated for CABG 10 days back, bilateral mild pedal edema, sternal wound appears healthy. What are your first thoughts? I'm very keen to know from your audience. What are you thinking? Why the chest pain? Why the shortness of breath? Anybody in the audience? What do you think are the potential problems? Anybody? Is there a mic to go around? Anybody wants to try a guess? Okay. All right, I'll grant it to you. It's lunchtime already, almost. So, just want to emphasize, one, if a patient post-surgery presents to you with chest pain, it's not necessarily, rather most of the times, it's not cardiac in origin. It can be muscular or just pain from the incisional side or from the sternum. So what do you do? How do you distinguish that? One, a very simple clinical examination, tenderness in the local chest, and a clear ECG would tell you that this patient has got pain of muscular origin. Most important thing is when you compare ECGs, pre and post, because these are patients who already have had MIs, have already developed STT changes in their EKG. So don't look for a pristinely new EKG. Rather, what you need to do is compare the immediate ECG with the pre or the post-op ECG and see if there are any new changes on the ECG. Third thing, always get a chest X-ray. Breathlessness, very common. Post-operatively, you can pick up effusions, you can pick up lung collapse, you can pick up pericardial effusions from an enlarged heart side. So no harm in trying to get. Let's not wait to get an echo done. If it's not an availability in a lot of peripheral centers, and a chest X-ray will give you a good enough idea about what's going on there. Again, bilateral pedal edema. Look if the patient has got his peripheral veins harvested. If a patient has got vein harvested, then bilateral pedal edema is very, very common. It does not necessarily indicate heart failure. Again, biomarkers. If you're going to go with TROP-Is, TROP-Ts, or your CPK-MBs, remember this. Patient on pump biomarkers can be aberrant for as long as 4 weeks after surgery. And last but not the least, giddiness. Most often patients are on insulin for diabetic management, so be cognizant of that fact. Then lightheadedness could be simply because of hypoglycemia. So keep your basics right and evaluate the patient as you would for any normal pathology, and I think you will get the nail right on the head. With that, thank you very much.
Thank you, Dr. Buddha, for excellent presentations. Any questions from the house? So one thing is very clear. Not all the patients with the post-operative patients should be referred immediately to the cardiac surgeons. We will not going to deal with it. One should have an open mind for it. And any initial case of any valves and CADs should be referred urgently to the surgeons. Okay.
Sir. Yes, sir. No, it is true, because a lot of patients have these neuropathic pains. The problem is whenever you do a lima or a rima harvest, you are bridging the chest wall anatomy. You're going to take down the lima, but as a collateral, you're going to damage the nerves which serve to supply the chest wall. So after the lima is down, the patient's gone home. These nervous pains continue to haunt this patient for a long time, and it's not unusual for these patients to have recurrent pains for months after surgery. But this is an acknowledged fact. We know about it, so information is the best guide for this. All right, thank you very much.
Thank you, Dr. Budhaditya sir, for this excellent talk. I would like to request our next speaker, Dr. Vikram Vora. Dr. Vikram Vora is the Chief Interventional Neurologist at RHL and has vast experience as a neurology specialist. His expertise is in the treatment of stroke, brain hemorrhage, Parkinson's, migraine, epilepsy, seizure, and spinal cord disorders. He has particular interest in interventional procedures in acute stroke. Sir, the stage is all yours.
Good afternoon. Good afternoon, everyone. I would like to thank you, first of all, Dr. Shitu, Dr. Virendra Singh sir, Dr. Ravindra, for giving me this opportunity. And it is really heartening to see so many people attending the conference at our own hospital. And it is even better that today is the day I am presenting this, because today has been proposed as World Stroke Thrombectomy Day. Thrombectomy has been proven to be the treatment for large vessel strokes, and still date, even after 6 or 7 years of the proven role of the treatment, it is still not available to majority of the patients. So the thing about World Stroke Thrombectomy Day is to make people more and more aware about the procedure. So let's begin the presentation with that note. So I'll just start a brief thing with the history of stroke. So strokes were first described in 400 BC by Hippocrates, and he was the one who said that one part of the brain controls the other part of the body, opposite side of the body. Circle of Willis was described in 17th century. First carotid surgery was documented in 18th century. First cerebral arteriogram was done in 1927, quite a long time back from today, but till 6 years back there was not much of a role for this treatment because it was not proven. Following that, every decade endarterectomy was proven, aspirin was proven, then smoking was associated with stroke, and then in 1996 the first treatment was approved, which was the IV thrombolytic drugs. Following that, endovascular management started coming up. In 1998, first trial was published for intraarterial administration of the drug. In 2005 and 2007, 2 systems were published for the endovascular management of stroke, but they were shown to be a failure in 2013. Just 2 years later, 5 more studies came out, and they showed that if we select patients appropriately and procedures are done safely, they are the treatment of choice, and they are one of the most effective treatments available in the full medicine for all sorts of diseases. There is something called number needed to treat, and this treatment has number needed to treat of 2, and that is available, I think, only for just 3 or 4 treatments in full medical penumbra. So let's begin with stroke. How to identify a stroke? This is a small mnemonic: be fast. Anything happening sudden can be a stroke. So be fast. B is balance, sudden loss of balance. E is eyes, sudden loss of vision in one or both the eyes. F is face, A is arms, S is speech. Anything affecting suddenly all of these things together or in isolation can be a stroke, and that is the time to go to the hospital as early as possible. So I will not go much into the theoretical part. Let's start with some cases. So this is a 70-year-old female. She presented with 3 hours history of sudden right-sided weakness with inability to speak and comprehend. NIHS is a score which is done in acute stroke, and it gives us an idea how severe the stroke is. The higher the score, more chances that it will be a large vessel stroke. Patient was a known case of rheumatic heart disease, status post mitral valve replacement. On acetylcholine, and her INR was 1.04. So we all can predict what was the reason for her stroke. She underwent a CT scan. I believe everyone can see this CT scan. Can someone pick up if there is something on this CT? So we can see a white streak like line-like thing in this CT. Rest of the CT appears more or less normal. So this is CT was done within first 6 hours, so likely to be normal. Other than this white streak, which is a thrombus sitting in the large middle cerebral artery. So obviously with high NIHSs and this finding, we think that patient is likely to have a large vessel stroke. But as our protocol, we give all patients a chance for IV drug, and simultaneously we shift patient for thrombectomy. So patient was given IV thrombolysis, shifted to cath lab. We could see very slow flow into the internal carotid artery up to the origin, up to the bifurcation of internal carotid artery. We took a microcatheter across it, placed a stent, took it out. There was some stenosis residual, and finally we did another pass. Pass means we gave another go with the stent, and we could open the vessel. Patient improved within next 2 days, and on the 4th day patient went home walking. So if done in appropriate time, it works almost like magic. The only thing is patient has to come in time and patient has to be picked up that this is the disease. We'll discuss a few things later, how to pick up whether patient has a large vessel stroke or not. Going to another case, 70-year-old male, repeated history of giddiness on walking in past, presented with sudden onset sense of rotation with imbalance which lasted for about 2 hours. He came to the hospital walking. Now how to suspect if it is central vertigo or peripheral vertigo? That is a very important thing to pick up in emergency, and quite a lot of time we miss it. Posterior fossa, the problem is CTs don't usually show the infarct or any other changes because there are a lot of artifacts. So this is a simple clinical test which can help us pick up even better than an MRI whether patient has a central origin for the symptoms. So it has 3 components: head impulse test, nystagmus, and skew deviation. So what is head impulse test? This is a small video demonstrating it. We tell patient to fix eyes on a certain thing and then give sudden jerks to the eye and see if the eye is lagging behind. So on that side it didn't lag, but on the other side we can see there is a corrective saccade. See, the eye is jerkily coming to the other side. So this is a positive head impulse test. If it is positive, it is suggestive of a peripheral origin of the vertigo. Going to the next thing, type of nystagmus. So if patient's nystagmus is gaze evoked and it starts beating in either of the sides, it is not fixed to one side, the fast component is not fixed to one side, then it is likely to be central origin. So here patient is looking on right side, the nystagmus beats on the right side towards the nose. Now we'll ask the patient to look on the other side. So now the eye beats on the other side. So this shows that it is likely to be a central origin nystagmus. If there is something else other than this, likely that the patient has nystagmus of peripheral origin. The third component, skew deviation. Skew deviation means both the eyes are not oriented in the same plane. They are up or down. So if head impulse test is negative, if patient has gaze evoked nystagmus beating on either direction with the gaze, or skew deviation is present, patient is likely to have a central origin for the etiology. Even if the MRI doesn't show the stroke, sometimes around 2 or 3% of the patient MRI may not show the stroke. We can still go ahead with IV thrombolysis and the stroke may be evident on the 3rd or 4th day MRI. So here we could see the infarcts and patient was thrombolized. Third case, 60-year-old male, 2-hour history of patient family side, he keeps on looking on one side, speech is slurred, and if asked, the patient says कि उसे कोई problem नहीं है, but the family says he cannot move his left side. Now, what can be the reason for this? Anyone can say? or what are these phenomena where patient will not report anything? So when right hemisphere is involved, patient will have neglect for his deficit. Neglect means he will have deficit, but he will not be aware of the problem. The family or the doctor can pick up the problem, but he will not be able to tell that he has left-sided weakness. So with this, we come to the point where we can pick up certain clinical things which will help us find out if patient has probable large vessel stroke and he may need thrombectomy. So in enteric circulation, if patient has aphasia, he is not speaking at all, he is speaking out of context of the problem. He has neglect, means he is not aware of what is his problem, usually seen in left-sided weakness. And gaze deviation, eye is fixed to one side, either right or left. So these are scenarios where large vessel occlusion is likely to be there. Even if CT is normal, the patient should be given IV thrombolysis, shifted to endovascular center. In posterior circulation, patient has alteration in consciousness. It is likely that patient will have a large vessel stroke. So again, this is the CT of the patient we are discussing who had left-sided weakness. Same thing, the hyperdense MCA sign. Patient taken for thrombectomy after IV thrombolysis and patient improved again within 2 days. This is the same patient. He had stenosis from the ICA origin itself. So we had to open his internal carotid artery in the neck. We had to open the middle cerebral artery in the brain. Both the circulations were closed. We had to open both the circulation, but patient did well because it was done in time. Now strokes are all sorts of things. It is not always ischemic stroke. So another patient, 40-year-old female, she complained sudden loss of consciousness for a few minutes, regained again. On regaining sensorium, she complained that before falling unconscious, she had severe headache. She had history of similar thunderclap headache a few days back. So any guess what it can be? Yeah, so it was SH, as we can all appreciate. Patient underwent DSA. We found a large posterior communicating artery aneurysm. We coiled it. Patient recovered in next 2 weeks and has been doing well after that. Another headache case, 28-year-old female, headache since 8 days, right hemicranial, normal fundus. She was on treatment for infertility and she gives no bad obstetric history. Any guess what this headache can be? So the clue here is a young female on treatment for infertility, likely to be a venous sinus thrombosis. So this is her MRI scan. We can see this white structure here which is not evident on the left side. So this is the acute thrombus sitting in the transverse sinus. Again, the same thing can be seen here also. This is the part where the transverse sinus through sigmoid sinus connects the jugular vein. So the thrombus was present. Again, on contrast imaging also we can see the same transverse sinus, but not in this transverse sinus. So she was first given 3 days of heparin infusion with ABTT monitoring, but still the sinus did not open up. Patient complained of severe headache. So now the role of endovascular procedure comes in. What we did was we did a DSA. We found there was no flow in this sinus. We took a microcatheter, placed it here in the sinus, gave patient urokinase and heparin into the transverse sinus for next 24 hours. Patient's headache improved within few hours. Next day check angiogram showed good flow across this sinus, and patient was maintained later on oral anticoagulants. So there are some red flags for all headaches where if present we can take patient up for early investigations. In our country, patients are very reluctant to get tests done. Even if we prescribe, they'll try to just continue their medication. But if one of these things are present, we should try to make them believe that they need to undergo early imaging. So this is a small mnemonic, SNOOP. So S is for systemic signs and symptoms like patient has fever, loss of weight, appetite, profuse sweating in night. Any neurological symptoms like hemiparesis, weakness, hemisensory loss, vision impairment. If the headache has been sudden onset, if patient is older and the headache is of recent onset, if the headache is progressive, it has been progressively worsening with the day. If patient reports any change in the headache severity with change of position, like it is more in the supine posture or more in the sitting posture, or if patient has papilloedema. If any or all of these signs are present, patient is likely to have a secondary headache and patient needs early investigation and management. So with this, I come to the end of my presentation. I hope I was not very fast. So if there are any questions, I'll be happy to answer.
Any questions, please?
because the very frequently get symptoms. One patient had got vertigo, and next day she had stroke.
Yeah.
So what symptoms to be careful?
Yeah. So in anterior circulation, there are no warning signs per se, but there are usually TIAs which are there. So in anterior circulation, patient may complain that he had sudden transient loss of vision on one eye. Or along with that, he may complain that he had some transient numbness, if with the eye symptom, then on the opposite side, or even without eye symptom on one side of the body. If there was any transient symptom and it resolved within few minutes or an hour, patient is likely to have some stroke-like event happening, which was a TIA, and patient recovered. So he needs urgent evaluation. In posterior circulation, vertigo is a very common presentation to all of our emergency. If vertigo is associated with some change in voice, patient is a diabetic or old age, if there was some change in his appearance, like the face became drooped on one side, or patient had some slurring of speech, they are all pointers that patient may have some central origin for his or her vertigo. And those patients are the ones which need early evaluation. Problem with evaluation is most of the time we do only CT scan or just a plain MRI. So CT scan will not pick up anything in TIA. Even MRI may be normal if patient had a TIA. So the important thing is to do a vessel imaging. Whether we do a CT angio or an MR angio, that is a different question, but those has to be done. In almost all strokes, patient has to undergo one vessel imaging at some point of time. If it done early, we can pick up those patients who will need early intervention, and we can avoid them to have large vessel stroke in future.
Do you recommend any medicine to give the patient before referring to you?
If CT is normal, we can always start patient on anticoagulation, but at least CT should be done. Without CT, we should not start on anticoagulation or antiplatelet for that matter.
Thank you.
Yeah.
Thank you, Dr. Vikram. And
Thank you,
I
sir.
thank my co-chair also. And with that, we end this session. Thank you.
Thank you, Dr. Vikram. Thank you, respected chairpersons. I would now like to invite chairpersons for the next session. Dr. Dinesh Mathur, sir. Dr. Arvind Gupta, sir. The next talk will be delivered by Dr. Ravindra Singh Rao, sir. The topic is Advances in Cardiac Treatment, Transcatheter Valves, State of Art in Robotic Angioplasty. I request sir to please come to the stage.
Good afternoon, everyone, respected chairpersons, and all the entire audience who's sitting here till the very end. Two great lectures which I heard, one from Dr. Buddhaditya and one from Dr. Vikram Bora, very educational and necessary for our clinical practice. So I've clubbed both my talks because we know it's very difficult to sit till the end of the program. My topic will be transcatheter valves and state of art angioplasty. Question to all of you. Which is the most deadly disease? Severe inoperable aortic stenosis, lung cancer, colorectal cancer, breast cancer, ovarian cancer, prostate cancer? Any guesses? Because it's highlighted in red. So I'll share with you the 5-year survival of severe aortic stenosis if that patient does not undergo a valve replacement. 3%. The survival of severe aortic stenosis who has not undergone a valve replacement is worse than lung cancer, colorectal cancer, breast cancer, ovarian cancer, and prostate cancer. And what we practice in our field is दवाइयों से चलता रहता है. No. Severe aortic stenosis, once a patient becomes symptomatic, there's a rapid downhill course, and 90% of these patients die within 3 to 5 years. And that is once the patient becomes symptomatic. So again, I would like to highlight, if the patient is asymptomatic, you continue this patient under follow-up, treat the risk factors, but once the symptoms start, there is a rapid downhill course. This is the whole spectrum of patients who undergo transcatheter aortic valve replacement. In 2008 to 2012, TAVI was only for patients who are high risk for open heart surgery. Not anymore. 2018, US FDA approved transcatheter aortic valve for even low risk patients. And in 2020, they said anybody above age of 65 years is a class 1 indication for a transcatheter aortic valve replacement. This is again, I'm not going to bore you with this whole data. There are two types of valve, which is bicuspid and tricuspid. We have enough data that in both the valve morphologies, the transcatheter aortic valve replacement does equally good. But another important myth, how long does the transcatheter valve last? Majority of patients come to us and tell us that this valve will last only 2 years. And then I ask them, who told you? They said, my physician said it's temporary hai. Not anymore. 1-to-1 data up till 8 years. And look at the data of hemodynamic performance. The transcatheter valve has better hemodynamic performance than the surgical tissue valve because the effective valve orifice area is more. 8 years, valve deterioration, 1-to-1 comparison based on Notion trial, the transcatheter valve does better than the surgical tissue valve. Bioprosthetic valve failure, what does that mean? The repeat surgeries and repeat replacements equal. The transcatheter valve up till 8 years does as good as a surgically implanted tissue valve. Again, all-cause mortality equal. And that is why in 2020, ACC/AHA placed transcatheter valve as a class 1 indication if you can replace the aortic valve by going through the femoral artery. We have published our highest outcome in the Indian Heart Journal of minimalistic transcatheter aortic valve replacement, and on the left side is our data compared to the 3 international published data, the STS code, the permanent pacemaker, and our data is comparable to the data which is published from US and Europe, even better in terms of pacemaker. Our pacemaker data is only 5.7%, mortality is 0.9%, stroke is only 1.8%. Let us look at this case scenario. 78-year-old female, prior double valve replacement, 19mm valve in aortic, 27 in mitral position. Now after 7 years, both the valves have degenerated. Medicines don't work in this patient. A redo open heart surgery is very high risk. And this is the echo finding where the valves are degenerated. We replace both the valves without surgery. This is an aortic position, a valve in valve, and a mitral position, again without surgery, by going from the femoral vein and the femoral artery. And this is how it looks on CT scan. Both the aortic valve and mitral valve have been replaced without surgery in this patient. And this is how they look like on the 3D echo machine and on the CT scan. The reason I want to stress is these procedures are only possible if we have a 3D TE machine, if we have a CT scan machine, and advanced radiological imaging. So this is a CT scan picture, and this is how the valve looks like in the aortic and mitral position. Another example, 52-year-old patient, severe AS, severe MS, mitral annular calcification, porcelain aorta, Hodgkin's lymphoma, chest wall radiotherapy, first degree heart block, RBB, LHB. Such patients are inoperable, and that's because they have so much of calcium in the ascending aorta that surgeons can't put a clamp, and they are called as prohibitive risk or high risk for a surgery. We did double valve replacement by replacing the aortic valve and the mitral valve, both by transcatheter procedure. And this is how they look on CT scan. And this was the first case in the country of 2 valve replacement by doing a catheter procedure. What about valve and blockages? Can we treat both in the same setting? 84-year-old patient, severe AS, severe LV dysfunction, NYHA class 3, moderate COPD, diabetes, prior PCI renal function. And so what we do in such patients, this patient had a left main disease, so we would put a stent in the left main, and then we would put a transcatheter aortic valve. So again, this patient is high risk for surgery, but this procedure is done under conscious sedation. There is no general anesthesia. Dr. Prashant Varshney is our specialist in this conscious sedation TAVI. So for patient, this is like general anesthesia. For us, it is like local anesthesia. Both aortic valve and the stent was placed. And do you know, can you imagine the size of the incision? That's it. This is the small needle hole in the groin, which we have already closed with a ProGlide suture, and through this minimal needle-like hole, we would go ahead and replace the valve and put a stent in such patients. We are also the first center to start the new valve, which was done first time in the country using an Abbott valve. We also come across a lot of patients who have heart failure, and their EF is 25%, and they have severe mitral regurgitation. What can we offer for such patients? We do something called a mitra clip. What it is, we will repair the mitral valve again without surgery by going from the femoral vein. He is a 65-year-old male, had a bypass surgery in 2020, residual severe MR, NYHA class 3 to 4. He was hospitalized 5 times in 6 months, last admission for a month. He was transferred from UP on milrinone, NORAD for past 2 weeks. He came to us. I'm not going to bore you with these details, but for the interest, this is severe mitral regurgitation, and this patient already had undergone a bypass surgery. You can see on the fluoroscopy the sutures. So we put a clip, the mitral regurgitation vanished on table. Post-procedure, this patient had residual mild mitral regurgitation. And this is how the patient spent next 4 days in our hospital. You know, he was sitting with his family, he was playing cards, he walked in our hospital corridor, and he said he hadn't done this in past 6 months. And a happy patient was discharged home on 5th June. What do we do in state-of-art angioplasty? Cardiogenic shock. 55-year-old male presented to the ER with chest pain. While entering the ER, collapsed. CPR was started, intubated. After 30 minutes of CPR, patient was revived on inotropes. What next? So, as I had a lecture yesterday about timing of revascularization, such patients are very high risk for open heart surgery. So we did an ECMO-guided angioplasty in this patient, and this patient's all 3 vessels were treated with ECMO rotablator, and this was again the first case in Rajasthan and second in India to do an ECMO-assisted rota PCI of left main. Here is an example of an impella-guided angioplasty, 3-vessel disease, high risk for CABG. We would put an impella. So impella is the smallest artificial heart pump. It delivers a cardiac output of 2.5 to 4 liters, and it allows us time to fix the blockages in such patients. Because once the blood flow is established, then only the myocardium starts opening, and this is how rotablator looks like. You can see a diamond burr where it goes inside the coronary arteries. We would ablate the entire calcium, remove the calcium, and do an angioplasty. Similarly, an 80-year-old male, severe COPD, non-STEMI, EF of 30%, thickness preserved on echo, cardiac MRI suggestive of viability, no mitral regurgitation, surgical turn down. Again, we would put an impella, and we would do a rota angioplasty of the main vessels. Here you can see this catheter. It's an impella heart pump which provides a cardiac output of 2.5 to 5 liters. Can anybody tell me what is the cardiac output in 1 minute? Normal cardiac output? Perfect, 5 liters. Can you imagine? I mean, once we start and you tell this to the patient, then the patient understands that when you are sitting at rest, your heart is pumping 5 liters of blood every minute. And after a heart attack, this cardiac output comes down to almost 1.5 to 2 liters. And then you need these assist devices so that all organs, and then the kidney starts failing, and then the liver starts failing. It's called cardiorenal syndrome, cardiohepato syndrome, and then the lungs start failing. So it's very important for us to do timely intervention for such patients. So here is an impella-guided angioplasty of the main coronary arteries. Once that is done, the impella is removed, and these patients go home safely. So what is state-of-art angioplasty? Can anybody guess what is going on here? This is optical coherence tomography. If you can see in that video, we would go inside the coronary artery, we would take imaging, and we see how well the stent is apposed. So this is called imaging-guided angioplasty. No longer we are putting stents just by eyeballing, we would image them. And once you image the stent, the long-term results are much better. We have also started robotic angioplasty, which reduces the necessity for second stent in 10% of patients, reduces the radiation dose to the patient, is helpful in complex anatomy like positioning the stent at the ostium. Now, is there an evidence of state-of-art angioplasty? This is a very important slide because majority of our physicians, even cardiologists, are stuck with the data from 2005 and 2007. We are working in 2022. We have data on what is state-of-art angioplasty. With the state-of-art angioplasty, all-cause death has come down to less than 43% compared to what was happening in 2005 and 2006. So there is drastic improvement in the long-term outcome, the safety outcome, if the angioplasty is done by state-of-art angioplasty. I'm not going to tell you what is state-of-art angioplasty. Use of rotablator for a calcified blockage. We would remove the entire blockage, calcium, the plaque. Use of IVUS and OCT, which I showed you, the OCT. We would go inside the artery, see how the stent is well expanded. Use of FFR for a borderline blockage. Does that blockage really need a stent? Yesterday, there was a patient who was advised a stent at some peripheral hospital. Patient was pre-op for renal transplant. His renal transplant was turned down. We did an FFR and proved that your FFR is 0.9, you don't need a stent, and patient has been accepted for renal transplant in Chennai. Robotic angioplasty, I already showed. Impella angioplasty. Impella is for protect angioplasty. We would protect our patients from death on table. ECMO for cardiogenic shock. This is what we are doing in RHL, and that's how the outcome of the state-of-art angioplasty, which is already published in paper, is far, far superior and safer than the routine angioplasty. This I already shared yesterday. Our 1-year outcome, we did 447 angioplasties, 65 rotablators, 63 TAVI procedures, IVL angioplasty, 22, mitra clip, 8, IVUS OCT, 80 cases, 5 impella. Our procedural mortality for angioplasty is 0. We would like to promote a safe angioplasty in a complex situation. Our in-hospital mortality is 0.6%, and these are the 3 cases who had cardiogenic shock. TAVI intra-procedure mortality is 0, in-hospital mortality is 0. We are Center of Excellence for transcatheter valve and structural heart disease. We are Center of Excellence for CHIP. CHIP is Complex High-Risk Indicated Angioplasty, Cardiogenic Shock Center, and Aortic Center. We also published our intravascular lithotripsy data in Indian Heart Journal of the outcomes. We had patients who traveled from all across the country for advanced cardiac treatments as far as Dubai and Bangladesh. Take-home message, TAVI has become a class 1 treatment for severe AS patients. Mitra clip saves patients with severe MR and heart failure. Cardiogenic shock carries high mortality, almost 60% mortality, but Impella has reduced the mortality by 50%, and it allows us to complete the angioplasty, and complex angioplasty is safe and long-lasting if it is done as per the state of angioplasty standards. Thank you very much for your kind attention.
Thank you, Dr. Ravindra. In fact, I never knew it that after doing I have qualified for sitting as a chairperson, because I have undergone all these rotablator and angioplasty, complex angioplasty, and I'm sitting last 1.5 years. So that qualifies me for becoming a chairperson. Thank you. And what you were talking about, the 5 liters of blood. Probably 5 liters of blood, and Budadit and other people will agree with me that your heart, you people are working on an organ which is pulsating almost 1 lakh times in a day, in 24 hours.
And that too from a distance.
That too from a distance, and pumping the 5 liters of blood in almost 1 lakh kilometers of blood vessels. If you take up those blood vessels in a linear length, it is almost 1 lakh. But at the same time, the lungs which are working at least 20 how much time the lungs they pulsate? 22,000 times in a day. So probably, and nowadays the science is advanced. When I remember when we did our MD medicine, Dr. Viren Singh will also agree with me. किसी के MI हो जाती थी तो 4 महीने तक उसको बिल्कुल 4 वीक तक तो जो है ना वो महीने भर तक तो लेटा रहता था, उसको घूमने नहीं देते. यहाँ एंजियोप्लास्टी करके सब कुछ करके दूसरे दिन तो जो है ना चला करके चला देते हैं. So something very congratulations for that.
Thank you, Dr. Rao. If any questions, before any questions, your excellent deliberations as usual. My question is very common question, that what are the contraindications for doing this TAVI? Specifically, I want to ask any relative contraindication or absolute contraindication. And like 70-year-old lady comes to us with the diagnosis of aortic stenosis and with the uncontrolled hypertension and uncontrolled diabetes. Whether you like to do TAVI in that case also?
Yes, sir. In fact, that is an ideal case for TAVI, because this patient is going to do comparatively, what I'm speaking is comparatively, this patient is going to do poor with surgery because this patient has more risk factors. But in the past, these patients used to undergo surgery. But because of these risk factors, this patient will do better with TAVI. So I'm going to give you an age spectrum of TAVI patients. I have done as young as 27-year-old lady who presented to us in the last trimester. She had had 4 abortions in the past. Severe AS was not diagnosed. So she was low risk for surgery, but the baby was a precious baby. So we did a transcatheter aortic valve replacement. She delivered a baby girl and she's doing fine. As old as 91-year-old who was active, independent, doing all their daily activities. So one of the contraindications for TAVI would be a requirement of a metallic valve. So if patient needs a metallic valve, then patient is not a candidate for transcatheter aortic valve replacement because the TAVI valve is a tissue valve.
So there is no contraindication as such.
There are certain anatomical contraindications. So no physiological contraindications if patient qualifies for a tissue valve, but anatomy-wise we would do a CT scan and there would be certain anatomical contraindications where patient can be turned on for TAVI.
Thank you. Any questions from the floor? No?
Thank you so much.
Thank you very much.
Thank you very much, sir. I would now like to invite Dr. Narendra Rumta, sir, to deliver his talk on fluid management, evaluation and optimization.
Good afternoon, friends. And after a very high-fi lecture, advanced technology, I'll talk about the grounded problems that you see day to day. Fluid therapy, dehydration, leg problems, and patient getting dehydrated without fluid loss outside. Apparently, he is severely dehydrated, he is in hypovolemic shock, but you don't have diarrhea, you don't have vomiting. Still, the patient is dehydrated, requires fluid, and since it is a day-to-day problem, whatever disease, whether it is TAVI or stroke or any other related to pregnancy, fluid therapy will come into fore, whether to give or not to give, and how to give, when to stop. So fluid therapy in sick patients, evaluation and optimization. Both evaluation and optimization are tricks and requires clinical acumen rather than mathematics. And for that, we should be able to understand fluid homeostasis in the body as it exists, to evaluate fluid balances in a sick patient, and to understand how can we optimize fluid therapy and where to stop and where to initiate, how much, how fast, how slow. So human body is like Mother Earth. Earth water surface is almost 71% of the whole Earth surface, and only 3.5% of the whole water is potable. Similarly, in human body, from newborn to adulthood, we have percentage of water as 70%, 65%, 60%, and so on and so forth. And only about 2.5 liters against, corollary of potable water in universe, we have 2.5 liters of water circulating as plasma, as a part of plasma. Plasma, blood is about 40% of blood is water. The rest is all solid, semi-solid, etc., etc. So, the rest of the water is distributed elsewhere and doing some other function. So, how it is distributed? This is the distribution of plasma is about 90% water, and what is blood plasma? Blood plasma is about, and the body fluid is distributed classically as we describe it as extracellular and intracellular. Extracellular is again two parts, interstitial and plasma or blood. And most of the fluid, 2/3 of about 50 liters or 60 liters or 40 liters, whatever water that human body has is resting in cells, doing its function, maintaining its normal metabolic function, its good health. If more fluid goes into the cells, it swells up and dies. And if fluid moves from the cells, it dries up and dies again. So the margin of safety into the intracellular area is very, very low, and it is marginal. So most of the buffering mechanism when fluid loss occurs either from the interstitial space or through plasma is maintained by the interstitial water. And whenever there is something wrong going on, loss of fluid inside the body water system assisted by various centers in the body act in a manner so as to maintain the plasma volume first. So the first attempt always is to maintain plasma volume as much as possible. And then there is an attempt to maintain the cellular water. Because unless we have plasma volume maintained, we will have hemodynamic problems, loss of blood pressure, loss of oxygen delivery, oxygen compromise, non-availability of oxygen to the tissues, and we will have anaerobic metabolism taking over, and we have lactic acidosis, and death will ensue very, very fast. And at the end of it, there will be organ hypofunctioning. So the first attempt is to maintain plasma volume, and when that is achieved, or if it is not achieved, then cellular health must be maintained. And when the cellular health comes at risk or starts getting hampered, then you become symptomatic. And symptoms, you have cold and clammy skin and a shock patient. What is that? That is manifestation of reduced circulation to skin. Then we have hypofunctioning of GI, that is reduced perfusion of the GI, and then subsequently you may get drowsy, that is early drying up of the brain cells, and then you have fall in urine output and metabolic acidosis. That is reflected as a fast and deep respiratory pattern. So everything is reflected, and when you have drowsiness, cold and clammy skin, hypofunctioning of GI, and fall in urine output, you must be quite alert that yes, the buffer system is failing and the cells are getting affected. Patient is becoming hemodynamically disturbed. So as soon as this happens, we see symptomatic patients, and therefore all patients arriving in our emergency rooms, they have dried up buffer system. They have dried up interstitium. So all of them would need fluid, and fluids upfront very fast. So the risk and its assessment. Plasma volume reduction leads to hemodynamic compromise, fall in BP, organ hypoperfusion, oxygen delivery is compromised, and transport of nutritional and other essential elements to be supplied from various parts of the body to the other parts is disturbed. So there is an intracellular drying up and the patient becomes symptomatic. Therefore, it becomes very clear that fluid replacement should be started as soon as any of the following is noted: hypotension, tachycardia, tachypnea, fall in urine output, which is indicator of renal hypoperfusion, patient feels thirsty, and there is cold and clammy skin, or patient is feeling drowsy, uncommon behavior. That means his neurological cells are getting affected, and therefore there is urgent need to replenish the interstitial space. Actually, we infuse fluid into the vascular space. From there, very fast it is transported to the interstitial space. So what do we need now? We have to select a fluid, we have to select the dose, we have to select a speed for optimization. So the type of the fluid to be administered, dose, rate, endpoints of the fluid therapy that we are targeting, and monitoring of the safety limits. कहीं ज़्यादा तो नहीं दे दिया, pulmonary edema हो गया ये. So we have to be very watchful while we are doing this, because we do very aggressive fluid therapy in symptomatic patients. The classification of fluid that we use is based on their ability to pass through the barriers, the barrier membrane between interstitial compartment and the cellular compartment and the plasma. इन तीनों चैम्बर्स और तीनों एरियाज के बीच में जब क्रिस क्रॉस होता है वाटर, that classifies a particular solution or a fluid that we use in routine for infusion into the patients. And that is very, very important. And therefore, we have two types of fluid. One is called crystalloids, another is called colloids. And the commonest crystalloid that is used is normal saline. Then we have ringer lactate or acetate, dextrose solutions, 5%. Fortunately, I was holding it. Buffer crystalloids, or what is called as balanced solutions. I can hold it. And colloids, we have albumin, pentastarch, and HES. And it is very, very popular. Still, a lot of my friends are quite fond of using colloids, particularly in their anesthesia practice. I think in critical care practices, the use of colloids have declined to a large extent, but I would not say that it has been totally eliminated. Now I talk about normal saline a little bit, because this is the commonest fluid that we use. I think almost 95–96% times we use normal saline. It is the most abundant, sodium is the most abundant electrolyte which is present in ECF, and so in interstitial fluid also. Therefore, when we give normal saline to a patient, therefore automatically it will find its own place, because it is isotonic. It is isotonic with plasma, and it is isotonic with interstitial fluid as well. Therefore, there is no problem in movement of normal saline into plasma and into the interstitial fluid. If the cells are dried up, if the cells are deficient of water, then automatically, because of gradient, hydrostatic gradients, water will flow into the cells. It will find entry into the cells because of hydrostatic gradients. Therefore, exogenous administration of sodium-containing fluid will find its own destination very smoothly and spontaneously. This means that the predominant effect of volume resuscitation in sodium is to expand the interstitial. जरा सा इसको move कर देना है ना, मैं उससे बोलूँगा, आप move कर दो. So this means that the predominant effect of our target place compartment is interstitial rather than intravascular. Because we go into the intravascular area, the fluid starts circulating, but very soon it goes into the deficient compartment of interstitium, from where it is distributed wherever it is required. Can I have the next slide? Yes. Now, dextrose is also a very, very popular fluid of choice in administration, and it is very difficult, very hard to convince my friends, particularly the younger ones who graduate or post-graduate out from medical colleges in recent past, that probably dextrose 5% or 10% or GNS for that purpose is not the best fluid. Why? Dextrose is a common additive in intravenous solution. 5% dextrose in water solution is not a volume expander at all. It does not expand volume in any manner. The use of 5% dextrose solution was originally intended to supply non-protein calorie and thus provide a protein sparing effect. Now this is quite funny. Why funny? Because 5% glucose means a liter of 5% dextrose would provide about 50 grams of glucose. That means about, multiply by 5, about 250 calories. Now the current practice is each ml of fluid water that you give to the patient, whether orally, enterally or IV, should provide 1 calorie. And this particular solution provides 1 liter. You require 1 liter. That's a very high volume, and a solution which will not expand the interstitial volume, which will not expand the intravascular volume. Therefore, the concept of 5% dextrose solution providing calorie is absolutely out of place. It has gone, vanished, and stands no scrutiny these days. And it should not be used if, however, the fluid of choice in hypernatremia, because sodium is already very high in the circulating volume, and then you need to give apparently hypotonic solution to these patients to bring down percentage of sodium into the circulating volume and into the interstitial fluid. Therefore, I will request my friends to stop using 5% or 10% dextrose or dextrose containing any solutions for that matter. Now, if we give 1 liter of sodium containing solution, that is normal saline, only 20% of it is retained in the intravascular compartment. Whereas if you give 5% dextrose, only 7% remains into the intravascular volume. So the difference is almost 3 times without any advantages, and I have not included many slides because of paucity of time. At the end of it, dextrose will produce carbon dioxide. More burden on our system, metabolism, lungs, to eliminate that additional CO2. And somewhere down the line in metabolism, glucose is also a substrate for lactate production if your availability of oxygen somewhere is compromised. So those patients who will get lot of dextrose infusions. Therefore, I always say that patients where you want to give 50% dextrose or 25% dextrose, don't give boluses. These boluses are not utilized because the patient's metabolic system is already under stress and strain. Give them slow. At one stroke, you can give about 10 ml to find that your blood sugar is somewhere around 100 or 120. Then maintain your blood sugar with a slow infusion of 5 ml or 10 ml or even 2.5 to titrate it. Right. So this is the Cochrane database meta-analysis, which is quite convincing that saline is the best infusate to be used in these patients. Next. Colloids are very large molecules, and the philosophy is if we give large molecule based solutions to patients who are hypovolemic, and there is difficulty in giving them large volumes of fluid, particularly in cardiac patients, probably this molecule will stay longer in circulation and will draw more fluid in from the third space into it. But that is far from the fact. A lot of theoretical basis has gone into these thoughts. There is no practical basis. And by the way, if you end up giving albumin very fast, you have a strong chance of producing pulmonary edema. I will go very fast, Chetu, right? But because it's very difficult to justify. So next. So now there is another very important issue when we give very high volume of fluid to patients who apparently appear edematous. अरे साहब इसको तो ऑलरेडी इतना इडीमा हो रहा है और आप इसको 2 लीटर फ्लूइड, 2.5 लीटर फ्लूइड, 3 लीटर फ्लूइड दे रहे हो. You know what happens? The body loses water into its own third spaces when you have marked vasodilatation. Marked vasodilatation is classical of sepsis. It occurs in various distributive shocks, spinal shock, neurogenic shocks, and circulatory system which is meant for about 5 liters of blood cardiac output becomes 20 liters, 15 liters, or in some of the workers have reported it as much as 30 liters. But where it is all lying into the third dependent spaces of the body, into the interstitial space. So most of the circulating volume goes into the third space where it is lying idle and it is not into the circulation. Second is in the situations of increased permeability of the capillaries. That classically happens in tropical fevers like dengue, malaria, scrub typhus, even in sepsis, the capillaries become porous and lot of fluid flows into the third space and the patient bleeds or dehydrates into his own tissues and moves into, these patients have ascites, these patients have pleural effusion, pericardial effusion, and even several edema, and there is no fluid, there is no urine in the urinary bladder where it should be. Therefore, in these situations of edema, you should be very sure that it is not edema because of cardiac problems. And if you can exclude the cardiac problems because by your clinical experience and some diagnostic tools, then you have to give fluid very, very fast, and the usual etiology is very, very serious and the patient is likely to have very guarded prognosis. Next. So there are lots of studies. I have only included one, crystalloids versus colloids. Crystalloids have no match, and therefore crystalloids are fluids of choice, and normal saline is the one. Ringer is a close second, but again Ringer has certain disadvantages, and it has not proven any advantages over normal saline. Next. So the question now again usual in emergency rooms in ICU, does my patient need fluid? He is edematous. I have already given him 2 liters, 3 liters. He is on noradrenaline for some time. So when the answer obviously is a yes, then there is no problem, but not sure, then CVP is the easiest tool that you can monitor. Next. Next. So So CVP2, MAP 70, urine output 2 ml per kg per hour. In these patients, you have good MAP, good urine output, so fluid may not be needed. But when CVP is still 12, MAP is 60, on the lower side, urine output is low or non-existent, then you may need fluid resuscitation. Again, these are tricky decisions to be taken. Next. So after this infusion, this patient has MAP 60, heart rate increased, CVP has increased, and urine is only 20 ml per hour, then this is a bad patient to have received fluid. So we can stop fluid therapy there, but if there is a same patient after receiving 500 normal saline over 30 minutes, next. MAP increases, CVP increases, but urine output also comes, then we don't worry about CVP. We just maintain a very, very close watch on CVP, and since patient is responsive to fluid, then it's a little tricky, but we move forward with fluid therapy. Next. So fluid may be given at a rate of 500 to 1000 ml per hour of crystalloid, or even faster if the patient is in shock. The surviving sepsis guidelines, universally accepted now, guides us to give almost 3 liters of normal saline in about 1 to 2 hours time. Next. So this is a tightrope walk. Our target is always to restore perfusion, correct hypotension, adequate and prepare the patient for use of vasoactive drugs, but at the same time we should be wary of pulmonary edema. Next. So there are few tests. Passive leg raising maneuver is a very important handy tool. Patient का 45 degrees or even more 60 degrees तक उनका legs ले जाइए while he is lying in bed. Keep it in that position for about 3 to 5 minutes. If the patient's blood pressure increases by 10 millimeters of mercury, probably the patient is fluid deficient, and this is a very, very handy, and this is reversible. If the patient develops pulmonary edema, then you can reverse it in a minute and patient will be back to his original condition. Right. MAP. We usually concentrate at MAP. So this is passive leg raising test. Next. What is MAP? So IV collapsibility has been talked about several times during last 2 days, so we can skip. Next. So endpoints. So what are the endpoints? As we call it, optimization. So endpoints are MAP 70 or more, urine output of 2 ml per kg per hour, sensorium improved, patient is no more drowsy, which indicates the cells have been revitalized, rehydrated, and there is no deficiency of water in the cellular area. Pulse rate has is started coming down towards normal, and SCVO2, which is oxygen at the junction of superior and inferior vena cava, and that should be more than 70. That means less than 30% of oxygen has been withdrawn by the tissues during each cardiac cycle. Next. So I will conclude. Normal saline remains the fluid of choice for very sick patients until more information is available, and I have been waiting for that information for last 30 years. It has not come, and more information has come in favor of normal saline. Colloids may induce AKI and altered coagulation and do not have any additional advantages. Albumin may be useful in some relative conditions where patient is hypoalbuminemic, and the definition of hypoalbuminemia is albumin less than 2.5 gram and is hypotensive. Glucose containing fluid should be discarded altogether. One of the top speakers in the world, he was commenting, I am still surprised why dextrose solutions 5%, 10% are manufactured and marketed. I don't find there, like many would talk, why I realized the use of horns only after landing into India. I was always thinking in my country, what is the use of horns in cars and vehicles? So when I landed in Delhi or in Bombay, I found that they are very, very useful. So early volume replacement is more important than quality of fluid. If you do not have normal saline or sodium containing fluid, then it is you choose to give any other fluid. Don't wait. 5% dextrose दूंगा ही नहीं, prestige issue नहीं बनाना है, fluid तो देना ही है. Continuous monitoring is important.
फ्लूइड देने की बात पे मेरे को भी बैठे बैठे ऐसे ही याद आ गया. मतलब यहाँ वो जो सामने एक डेलीगेट बैठे हुए थे, वो रहीम दास जी ने आज से कई सालों पहले कहा था, रहीमन पानी राखिए, बिन पानी सब सोन, पानी बिना न उबरे मोती मानस चून.
Very well brought out. So in Indian culture, Indian Vedas, water has been given the level of Atma Samman, life, part of Panchatattva. Body is made of Panchatattva, it is ultimately goes into Panchatattva. So the water philosophy, the basis of water, considering discussing water, it is never ending topic. MAP, urine output, improved sensorium are good endpoints. So Rahiman pani rakhiye bin pani soon, and if you make the body deficient of water, the patient may go into irreversible failure.
Right.
And at the same time, I must tell you, as Mother Earth behaves, excess of water is also bad, deficiency of water is also bad. But we are used to deficiency of water for some time, certain time. We are more tuned to living in famine conditions rather than in flood conditions, where there is large perishments of properties and human lives. So therefore, body tolerates dehydration more than pulmonary edema or overhydration. Therefore, overhydration at any point must be avoided.
So thank you very much, Dr. Narendra Rumta and Moti Manas Chun. मैं वो चून के अंदर कहीं पे जो है ना वो पानी कम नहीं पड़ जाए. So let us go ahead to the next.
Yes, Dr. Rumta.
Yes,
sir. I want to have a very quick answer about the two important scenarios. The patient has nausea and vomiting, already suffering from heart failure, and second is the chronic kidney disease, suppose stage 2. Chronic kidney disease or renal failure stage 2, where the patient is, we can't give too much of fluid, but patient is dehydrated. Now these two situations are very, very common, and how to deal with this?
So,
nephrologists say that we can't give 800 to 1000 milliliter.
So in these conditions, request Ravindra to lie in the bed in my duty room I keep requesting him to be by my side for help whenever I need him, and while I am giving, the fluids to this patient, hoping against hope that this patient would survive. At the same time, if there is some cardiac problem to develop, I am confident that Ravindra will take care. That is the answer in simplest terms. But say these are tricky situations. I am more inclined to give them fluids rather than, because if not give him fluid, if I don't give him fluids, deterioration is absolutely sure. But heart failure is a relative term. What level, what grade? So heart may be, even in.
I think we have got a very unpleasant duty of sitting on this chair to keep the things in time. So
I know, sir. So I am on my feet.
Please.
Yes.
NS?
You have the permission of the chair, sir?
Please, sir.
Yes. Yes.
So, in the severe gastroenteritis patients, should we use only normal saline?
Yes.
No other solution to be given?
Yes.
Thank you, sir.
Absolutely. There is no controversy about it.
Thank you, sir.
Even in newborns beyond 1 month.
Thank you.
So now we call upon Dr. Govind Sharma. Ajani, finish. You all finish. Oh. So now we have come to the end.
Thank you, dear chairpersons. I would now like to hand over the mic to Dr. Shitu Singh for a small valedictory prior to the main quiz. Dr. Shitu Singh.
So just before we start the final round of quiz, we have a small valedictory function, and I would like to call upon Dr. S.S. Agrawal, Chairman, Rajasthan Hospital, on the dais, Dr. Virendra Singh, President, RHL, Dr. Ravinder Singh Rao, Vice Chairman, RHL. I now request Dr. S.S. Agrawal to highlight the vision of RHL.
नीचे रख।
नमस्कार, वंदे मातरम। आज इस RHL हार्ट लंग अपडेट 2022 इसमें आप सब लोग बाग इस गर्मी के माहौल के अंदर लू में चलते हुए पूरे राजस्थान से कहाँ से पधारे हैं, उन सभी का मैं राजस्थान हॉस्पिटल की तरफ से बहुत बहुत स्वागत और अभिनंदन करता हूँ। आपने पिछले दोपहर से यहाँ पर बैठे हुए हैं और आपने देखा होगा कि मैं आज बड़े संतोष और विश्वास के साथ कह सकता हूँ कि राजस्थान हॉस्पिटल जिस उद्देश्य और जिस ऑब्जेक्टिव के साथ चालू किया गया था, मुझे संतोष है कि आज वह हम अपना प्रयोजन पूरा कर रहे हैं। राजस्थान हॉस्पिटल हमने एक विजन, मिशन और अपनी वैल्यूज के साथ चालू किया था। आपकी जानकारी के लिए राजस्थान हॉस्पिटल 20,000 मीटर लैंड एरिया के अंदर 3 लाख स्क्वायर फीट से ज़्यादा बिल्ट अप एरिया बना लिया है। ये 450 बेड्स का प्रोजेक्ट है। अभी 150 बेड्स ऑपरेटिव है और 250 बेड्स विदिन 3 मंथ्स हमारे चालू हो जाएंगे। मित्रों, ये सब आप लोगों की शुभकामनाएं और स्नेह है कि इस कोरोना जैसी महामारी के अंदर भी, जबकि हमारा अस्पताल केवल चालू होने का था, हमने आप सभी के शुभकामनाओं के कारण अपना एक विशेष नाम और कीर्तिमान पूरे राज्य में ही नहीं, राज्य के आसपास के सभी राज्यों के अंदर भी अपना नाम रोशन किया। हमने हमारा जो विजन बनाया, उस विजन के अंदर था कि हियरिंग फॉर ऑल, जो भी यहाँ आए उसकी सुनो। मिशन था और मिशन है कि क्वालिटी केयर एट अफोर्डेबल प्राइस, क्वालिटी केयर एट अफोर्डेबल प्राइस। और आज हम वह जो हमारा मिशन है उसको आप सबको जानकारी होगी कि हम उसको पूरा कर रहे हैं। हमारे यहाँ आपकी जानकारी के लिए जो सीटी स्कैन है वो केवल 2300, HRCT वो 2300 रुपये में होता है। एक्सरे केवल 170 रुपये में होता है जो डिजिटल है, और जो कंप्लीट ब्लड काउंट है वो भी केवल 120 रुपये में, 130 रुपये में होता है। इसी प्रकार ICU वगैरह के सबके, क्योंकि हमारा मिशन ही था और मिशन है और मिशन रहेगा कि क्वालिटी केयर एट अफोर्डेबल कॉस्ट। मित्रों, हमारी कोर वैल्यूज़ भी हमने बहुत ही सिंपल बनाई, और कोर वैल्यूज़ हमारी है केयर एंड ट्रस्ट। केयर, पेशेंट की केयर, और केयर के साथ साथ अगर हमारा पेशेंट हमारे अंदर ट्रस्ट करेगा या हम पेशेंट के अंदर ट्रस्ट करेंगे तो निश्चित रूप से हम जिस मिशन को लेकर, जिस ऑब्जेक्टिव को लेकर ये बनाया है वो आप सबके सहयोग स्नेह से हम पूरा कर पाएंगे। ट्रस्ट के अंदर आपको मालूम है कि TRUST, T ट्रांसपेरेंसी, ये हमारी हॉस्पिटल की कोर वैल्यू है, ट्रांसपेरेंसी। R रेस्पेक्ट, रेस्पेक्ट जो भी आए, चाहे पेशेंट हो, चाहे पेशेंट के अटेंडेंट हो या और कोई उनके साथ हो। तीसरी है U, ये कोर वैल्यूज है, अंडरस्टैंडिंग। अगर हम आपस के अंदर अंडरस्टैंड नहीं करेंगे पेशेंट को और हमारा स्टाफ या हमारे कंसल्टेंट, तो हम आगे कार्य नहीं कर पाएंगे। एस स्किल, जो भी यहाँ काम करें, चाहे रिसेप्शन में हो और चाहे कंसल्टेंट हो, चाहे GDA स्टाफ हो, चाहे सफाई कर्मी हो, सबकी अपनी अपनी स्किल होती है और स्किल सबके अंदर हो। अगर स्किल नहीं है तो हम जो अपनी सर्विसेज हैं वो एट द मार्क नहीं दे सकते हैं। और इसी प्रकार से है टीम वर्क। अगर ये सब भी हैं, स्किल भी है, ट्रांसपेरेंसी भी है, बाकी चीज़ें भी हैं, अंडरस्टैंडिंग भी है, लेकिन उन सब की टीम का काम नहीं है तो किसी भी तरीके से नहीं। इसलिए आज आपने देखा होगा कि राजस्थान अस्पताल के अंदर हम अपनी बहुत ही सिंपल जो कोर वैल्यू है, केयर एंड ट्रस्ट के ऊपर काम कर रहे हैं। 2 रोज के अंदर आपने देखा होगा यहाँ पर करीब करीब मेरे ख्याल से 30-35 से ज़्यादा लेक्चर्स हुए हैं। कितने? 30-35 हैं शितू? अच्छा, मैं करीब करीब 30 तो हुए ही हैं, क्योंकि जो टाइमिंग्स है और शायद 20-25 मिनट का एक है, इसके कारण इतने तो मैं 20 लेक्चर्स के अंदर हमारा जो था मेन कि किस प्रकार से हम अवेयरनेस का काम कर सकें, जिसके कारण क्वालिटी एक एक्सचेंज आपस के अंदर होने से और नई नए आयाम और अपनी स्किल इम्प्रूव होती है, तो वो अवेयरनेस और स्किल दोनों बढ़ाने के कारण ही हम किसी भी अपने मुकाम पर पहुंच सकते हैं। आपको जानकर ये प्रसन्नता होगी कि आज राजस्थान अस्पताल के अंदर करीब करीब सभी, केवल हार्ट और लंग जो आपने देखा, जिसके अंदर की हमारा एक विशेष नाम हमने पिछले 2 साल के अंदर लिया, और आज जो टावी के अंदर पूरे कंट्री के अंदर सबसे ज़्यादा प्रोसीजर के अंदर राजस्थान हॉस्पिटल है पूरे कंट्री के अंदर। और इसी प्रकार जो लंग्स के अंदर जो इंटरवेंशनल प्रोसीजर्स होते हैं, उस प्रोसीजर्स के अंदर बहुत से, तो आपको सबको मालूम भी होगा कि बहुत से प्रोसीजर तो केवल यहीं होते हैं, और उसके अंदर भी जो प्रोसीजर्स हैं वो पूरे के पूरे प्रदेश के अंदर हमारा नंबर 1 आता है। इसके अलावा भी चाहे आर्थोपेडिक्स हो, चाहे न्यूरो सर्जरी हो, चाहे अन्य जो हमारे कार्य जो डिपार्टमेंट्स हैं उनके अंदर भी, चाहे ईएनटी हो, चाहे स्किन हो, ये फिजियोथेरेपी है, यूरोलॉजी है, नेफ्रोलॉजी है। नेफ्रोलॉजी के अंदर हमारी करीब करीब इस टाइम 700 से ज़्यादा डायलिसिस पर मंथ हो रही है, जो कि अभी बिल्कुल चालू ही नहीं। डेंटल सर्विसेज, डायबिटीज़, ईएनटी, हार्ट्स हैं, ये सब जो हैं हमारे यहाँ पूर्ण रूप से चालू हैं और हम कर रहे हैं। आप लोगों के आशीर्वाद से हम अपने विजन, मिशन और कोर वैल्यूज़ को बनाए रखें। इसी प्रकार का हम आपसे स्नेह और आशीर्वाद चाहते रहेंगे। एक बार फिर आप सबको बहुत बहुत धन्यवाद, बहुत बहुत आभार, बहुत बहुत शुभकामनाएं। जय हिंद, जय भारत।
I now request Dr. Virendra Singh to please give the vote of thanks.
सबसे पहले आप सबको बहुत बहुत धन्यवाद कि इतना अच्छी तरह से आप आए, अच्छी तरह से मन लगा के सुना, और वो भी अनडिवाइडेड अटेंशन के साथ। और सिर्फ एंड सिर्फ मैंने एक चीज़ इंटरेस्टिंग नोट की, इन 2 दिनों के अंदर मोबाइल की घंटी रेयरेस्ट ऑफ रेयर थी, बल्कि आज मेरी बजी तो मुझे गिल्ट का अनुभव हुआ। उसके लिए, इस डिसिप्लिन के लिए आप सब को बहुत बहुत धन्यवाद। हमारा ये जो इस अपडेट का जो मेन क्रक्स ऑफ मिशन था, वो क्या है कि अपने यहाँ पर काफ़ी चीज़ों के अंदर कुछ छोटी छोटी चीज़ों की वजह से मोर्टेलिटी हो जाती है। तो मन में तमन्ना जगी कि क्यों ना हम अपग्रेड करें स्किल्स ऑफ एवरी कॉमन डॉक्टर, जिससे कि हम इन मोर्टेलिटी को बचा सकें। COPD टॉप मोर्टेलिटी इन राजस्थान में सेकंड इज हार्ट डिजीज़। दीज 2 आर मोस्ट कॉमन कोज ऑफ द मोर्टेलिटी। तो इसीलिए सोचा कि यदि थोड़ी थोड़ी टिप्स आप सीख जाएंगे तो इस चीज़ को कर पाएंगे। और ये हम क्यों कर पाए? क्योंकि ये एकमात्र ऐसा इस लेवल का अस्पताल है जो कि फैसिलिटीज़ में कॉरपोरेट से भी आगे है, लेकिन इट इज़ रन बाय डॉक्टर्स। जो हम लोगों का आपस के अंदर ये रहता है कि भाई चलो पेशेंट का हित कैसा हो। जैसे अभी डॉक्टर श्याम सुंदर ने बताया कि किस तरह से केयर एंड ट्रस्ट के साथ अपन आगे बढ़ें, किस तरह से एथिकल वैल्यूज़ के साथ हम अस्पताल को आगे ले ही जाएं। लेकिन बेसिक चीज़ ये है कि पेशेंट का सेफ्टी इंश्योर करें। काफ़ी बात इस बात पे होती है, वी आर लीस्ट कंसर्न कि हमारे लीस्ट नहीं कंसर्न तो है कि नंबर ऑफ एंजियोप्लास्टीज और ये सारी हों, लेकिन मोर कंसर्न कि सेफली हों। सेफ्टी ऑफ पेशेंट, चाहे वो कार्डियोथोरेसिक की हो, चाहे वो कार्डियोलॉजी की प्रोसीजर्स की हो, चाहे ऑर्थोपेडिक्स की हो, चाहे न्यूरो सर्जरी एंड न्यूरो इंटरवेंशन के साथ जैसे आपने देखा इनकी हों। तो यही हमारा बेसिकली है चीज़ की सेफ्टी आउटकम ले सकें। तो अंत में आपके और क्विज़ के बीच में या आपके और क्या आईपैड के बीच में हम नहीं आएंगे। एंड आई विश टू एवरीबडी गुड लक कि आप आईपैड इस क्विज़ के अंदर जीतें और सेकंड डे के अंदर ये हॉल आप पूरा भरा हुआ रहना, ये हमारे लिए एक बहुत बड़ी बात है। और अभी मैं श्याम सुंदर बात कर रहे थे कि यार अपन इसको एनुअल इवेंट बना देंगे, तो बोले हाँ बिल्कुल ज़रूरी है। तो कि एनुअल इवेंट के अंदर आगे से जिससे हम टिप्स दे सकें वो आप प्रैक्टिकल यूज़ करें, जिससे कि हमारे प्रदेश की जनता की अच्छी सेवा हो और मृत्यु में बचाव कर सकते हैं। बहुत बहुत धन्यवाद। थैंक यू।
Thank you. So we will proceed for quiz, and I would like to call my co-quiz master, Dr. Prashant Varshne, on stage. And so with bated breath, I think we all are waiting to know who all crossed the preliminary round. So meanwhile, small notice for the housekeeping to arrange for 2 more sofas on the stage, please. And if all the mics can be put on the table, the hand mics, please. Can you please flash this also? Tada! So the first is Dr. Sandeep Bhargav. Can you please...
Sandeep Bhargav.
Okay, so he's standing there. He won actually, he got 14 out of 15 correct answers. Second is Dr. Chetan Chaudhary. Wonderful, 13 by 15. Come on, a huge round of applause. Akhil Bansal, Dr. Manoj Kumar Mali, Dr. Apurv Mathur, and Dr. Himani Acharya. So please come on stage. So actually third, fourth, fifth were those people who got 12 out of 15 correct, but they did it in the shortest period of time. There were 2 other people on 12, but the time duration was longer, so we had to drop them. So we will be having it in 3 rounds. There will be no negative marking. You will get 40 seconds to answer one question. So once the time is up and you have not answered, that question can be given for the pass round. We can stand downstairs also, like it's okay. इसको थोड़ा सा टीवी को रोटेट कर सकते हैं? टीवी पे देख लेंगे. Can you please come on stage? 4, 5, 6. You can sit in any manner. The question will be passed on and you will get 40 seconds. Who is left? And there will be 2 people left, right? Okay. Dr. Sandeep Bhargav, Dr. Chetan Chaudhary, Akhil Bansal, Dr. Manoj Mali, Dr. Apurv Mathur, and Dr. Himani Acharya. So I think you have been right from the beginning. You were the first person. No, but you are here since yesterday, right from the lunch period. So let's start.
How we are going to start?
So how are we going to start?
Yeah.
will be 3 rounds. Each person will get 40 seconds. You know, once we have read the entire question and you start the MCQ, you will get 40 seconds. If you are not able to answer that, we will, you know, ask the rest of you and you can raise your hand if you know the answer. There will be no negative marking. So there will be 3 rounds, 1, 2, 3, one question in each round. So essentially all of you will be having 3 questions to answer and to win. So if one question is correct, you get 5, and if you answer another passed on question, you get another 5 marks. So Varun, please note down everyone's name. Dr. Apurv Mathur, Dr. Akhil Bansal. So I think let's please introduce yourself one by one. You can use this mic. And where are you from?
Good afternoon, everyone.
You can pass on the mic.
Good afternoon, everyone. Myself, Dr. Akhil Bansal, presently in Fortis Hospital, in Chest and TB department. Thank you, sir.
Good afternoon, everyone. Myself, Dr. Chetan Chaudhary, from Mahatma Gandhi Hospital, Emergency Medicine Department.
Good afternoon, everyone. My name is Dr. Apurv Mathur, and I am a junior resident at Mahatma Gandhi Hospital, Respiratory Medicine Department.
Good afternoon, everyone. Myself, Ibani Acharya. I am second year resident at IRD SMS Medical College.
Good afternoon, everyone. Myself, Sandeep Bangudwa, DNB resident from Jaipuria Hospital.
Good afternoon, everyone. Myself, Dr. Manoj Kumar Mali, Associate Professor, Medicine Department, SPMC Bikaner.
Sir, मेरे को भी नाम चाहिए. So we'll start around from this side. We'll go further question will be for the next person sitting next to the first contestant. Dr. Akhil Bansal. The first question is, which of the following beta blocker had not a proven benefit in RCT? Option A is carvedilol, B is bisoprolol, C is metoprolol, B nebivolol. Okay, nebivolol. Okay, right, correct. Reset.
So the next question goes to 5. So the next question is, 22-year-old male presented with shortness of breath on auscultation. Can we have the audio file, please? What is the diagnosis? Time starts now.
Tension pneumothorax.
Good. He gets 5 marks.
44-year-old male found unresponsive at jogging track. Patient is not breathing and central pulses are absent. Now, what is the next step? Option is start chest compression, call for help. Option C is start artificial breathing, open the airway, and Hamlick's maneuver.
First, we call for help. We check the scene, and then we start the maneuver. The first is call for help.
Okay, that's right. 5 marks to him.
Next question to Hemani. 55-year-old male presented with shortness of breath and dysphagia to solids. This is what you hear on auscultation. Time starts now. This is carcinoma lung, goiter, bronchogenic cyst, neuroendocrine tumor. And this is classically a retrosternal goiter, which has, extended from the neck. And the sound is a striker.
Next question. Which of the following is not a class 1 antihypertensive? Option A, calcium channel blockers. Option B, ARBs. Option C, thiazide diuretics. Option D, beta blockers.
Beta blockers.
Okay. Is the right answer? 5 marks to Sandeep.
Dr. Manu, this is your question. Never smoking 22-year-old male with no past medical history presented to emergency department with sudden onset, sharp chest pain and right-sided neck pain. This is what you see on X-ray and this is the CT scan. What is the diagnosis? 1. Pneumothorax with pneumomediastinum. 2. Pneumothorax with pneumorhexis. 3. Pneumomediastinum with subcutaneous emphysema. And 4. Pneumomediastinum with pneumorhexis.
CT. Options?
Time is up. Anyone else will like to attempt? Please raise your hand. Okay, so Dr. Akhil.
Option 4, pneumomediastinum with pneumorhexis.
Okay, correct. So Dr. Akhil gets 5 bonus points. So this is indeed pneumomedia. Can you just show the X-ray just for the audience because they are sitting? What you see here is pneumomediastinum. But when you have air in the spinal cord, it is called as pneumorhexis. So this patient had pneumomediastinum with pneumorhexis.
Okay. Here we end.
Before we go to round 2, can you please elaborate the marks for each person? Dr. Akhil is at 10. Dr. I think he's leading the pack. So we still have 2 rounds, so buck up. Round 2, the first question to Dr. Akhil. 39-year-old lady presented to her primary care provider with dyspnea and cough, non-smoker, no relevant occupational exposures. This is the spirometry and you can see the curves. Spirometry is suggestive of. Your time starts now. 1. Normal. 2. Restriction. 3. Obstruction with poor reversibility. And 4. Obstruction with reversibility.
Option 2, restriction.
Any of these 4 options you have to answer.
Yes, option 2, restriction.
Restriction?
Yes.
Okay. So this is a wrong answer. It is actually obstruction with reversibility. The first thing is you have to see the actual value. I have actually highlighted it also, which is 0.59. That means it is an obstruction. And then you look at the reversibility for FEV1. What you see is a bronchodilator reversibility of 49%. And if you see what in the FEV1, from 0.93 it has increased to 1.39. So the rule is 200 ml and 12%. It is fitting that. So it is obstruction with reversibility, that is 4th.
40-year-old male recently had EORTI, presented with complaints of subacute chest pain, which is relating to trapezius. EKG done, which is there on the monitor, and patient has also had the elevated cardiac biomarkers. Best line of management for this patient. Options are loading with Dispirin and Clopidogrel, injection heparin 5000 intestinal units IV stat, shift to cath lab for primary PCI, or tab aspirin 650 mg thrice a day.
Best treatment we have to
Yeah.
shift to the cath lab for primary PCI.
That's a wrong answer. Yeah. If you go through the history, the patient has a recent URTI and patient has subacute change with pain, chest pain, and rating to trapezius. It is typical of the pericarditis. And simultaneously, you can see the all over there is a ST elevation with the depressed PR, concaving this thing, PR intervals. So the best management is for Dispirin 650 milligram thrice a day.
This is very important. Chest pain radiating to trapezius, it is pericarditis. And if you have a global ST elevation, or that is again indicates of pericarditis with PR depression. So you look at AVR. In AVR, if there is PR elevation and ST depression, it is pericarditis.
Next.
So none has scored till now. Good luck for the next one. 51-year-old man presented to his primary care provider with complaints of increasing dyspnea on exertion. He has 40-pack years history of smoking and is retired following a career in a building contractor. His PFT is as follows, and these are the graphs. So what is the diagnosis? 1. Normal. 2. Restriction. 3. Airway obstruction with bronchodilator reversibility. 4. Airway obstruction without BDR.
Option 4.
Wonderful. So this is the correct answer, and you can actually see the history also. He's a smoker, 51-year-old. So you actually expect a COPD, not a reversibility.
Next question for.
Next
question, Himani. A 75-year-old male patient admitted in CCU for congestive heart failure. He was stable after putting him on CPAP and diuretics. On lab investigation, he found to have hyponatremia with serum sodium level of 119 millimole per liter. On examination, patient is alert, conscious, oriented, and normal higher mental functions. What is the next line of management? 3% saline, normal saline, tolvaptan, rustic free water, and nothing.
Normal saline.
That's a wrong answer. Anyone from the audience?
Answer you can answer, but there are no marks.
Yeah. Chetan. That's right.
So, just for the education of everybody, such a situation never give 3% saline. Restrict free water. If you give more sodium to a hyponatremic heart failure patient, you become more hyponatremic.
I think next is Sandeep. And again a spirometry question. 45-year-old complains of dyspnea on exertion, cough since past 3 months, known case of rheumatoid arthritis. She was lifelong non-smoker and had history of no pulmonary disease in the past. This is the spirometry. The PFT is suggestive of, time starts now, 1. Obstruction with hyperinflation, 2. Obstruction, 3. Restriction, 4. Normal.
Restriction.
Restriction, that's the correct answer. So the clue here is that this is a follow-up case of rheumatoid arthritis. Dyspnea, you expect an ILD probably. One is, you look at the FEV1 by FVC, actual is 92, so anything more than 70 is normal. Next step is to look at the FVC. Anything less than 80 is a restriction.
Next question. A 65-year-old male post CABG with the ejection fraction of 25 to 30% presented to ER with CHF. EKG done. 2D echo shows severe central MR with dilated LV with jerky septum. Patient is on maximum tolerable dose of ARNI, beta blocker, SGLT2 inhibitors, and diuretics. Now what next? Mitral valve repair, CRTD, mitral clip, LVAD, or heart transplant?
Mitral valve repair?
That's a wrong answer. Yeah? No, that's a wrong answer. No, that's a wrong answer. Basically, the patient is having, on ECG, he is having a LBBB, which is very much significant, that QRS duration of around 150 milliseconds. And this signifies that septum is not taking part in the contractility of the heart. So basically, we are supposed to synchronize the contractility of the heart by putting a CRTD in that. And after that, if patient doesn't improve, we can go for mitral clip afterwards. But we have to put CRTD first, and then we are supposed to go for mitral clip. Rounds ends here. So what's the score, sir?
The score, Dr. Akhil at 10, Dr. Sandeep at 10, Dr. Apurva at 10, Dr. Chetan 5, Dr. Manoj yet to score, and Dr. Himani yet to score.
Come on, Baka, we still have one more round.
Then round 3. First question for the Dr. Akhil. Yeah, we can. We are okay. Anyway, Dr. Manoj. Question is 65-year-old male diabetic, hypertensive, presented to ER with retrosternal chest pain. EKG is there, and and on investigation he has raised TROP-T. Patient diagnosed as STEMI and taken for primary PCI. On CAG, LCX was thrombotic and 100% occluded. PCI and stenting was done. Patient was stable and shifted to CCU. Post PCI day 2, patient became hypertensive suddenly and presented with symptoms of shock and LVF. EKG again done, which doesn't show any changes, new changes. What is the most likely diagnosis for this patient? Options are aortic dissection, post-MI VSR, reinfarct, or pulmonary embolism.
Post-MI VSR?
That's the right answer. Basically, any patient presenting with inferior wall MI, EKG is showing inferior wall MI because as there are 2-3 AVF ST elevation. After even doing the angioplasty and PCI, the patient gets present with complication like VSR and mitral wall prolapse even after the 14 days and 21 days.
Next question to Dr. Sandeep. So, which of the following curves suggest fixed airway obstruction? The diagnosis is, time starts now, A, B, C or D. Lot of murmur in the audience. Let's not prompt them. This is easy, Sandeep. We had it yesterday.
A.
What did you say?
Option A.
A? Please loudly, I can't hear you.
Option A.
A? Yes, correct. So right on time.
Himani. Next question to Himani. A 20-year-old male goes to gym doing heavy weights. He experienced sudden onset of pain in the right upper limb, which resolved spontaneously. 72 hours later, pain reappears with tender swelling of the right upper arm. But he is able to lift his arm, move his arm. There is no exaggeration of the pain on moving. Most probable causes cerulean alba dolens, Paget-Shorter syndrome, thoracic outlet syndrome, or tear of deltoid head.
Option B.
Sorry?
Option B.
Option B is Paget-Shorter syndrome. That's the right answer. Basically, Paget-Shorter syndrome is the effort-induced thrombosis of the axillary and subclavian artery. And the patient presents with the edema of the limb because of the venous obstruction later on. Next question.
Patient of COPD had developed pneumonia. His ABG is as follows. pH 7.24, PO 250, PCO 260, bicarbs 26 on room air. Please calculate the arterioalveolar gradient. So I think, do you have a pen, paper? Anupriya, can you pass them a pen? think you have to memorize. Let's see how many of you attended it. Please carry on. So it's a past question. Others can also try, be ready with the answer. Okay. Try. No. Anyone else? It can be passed on. No guesses also, come on. Okay, so Chetan. Correct. B is the answer, 125. Come on, we all have given MCQ question. You could have answered anyone. 1/4 chances of being correct. Chetan gets 5 marks. For fluke.
Okay. Next question for the Chetan again. 45-year-old male presented to ER complaining of retrosternal chest pain, which varies with postural variation. And he had a low-grade fever for 3 to 4 weeks. On examination, heart rate is 110 per minute, blood pressure is 96 by 66 millimeter of mercury. Patient has a raised GBP, and which further raises during inspiration. His EKG done, which shows this thing, and the patient is having A. constriction pericarditis, B. cardiac tamponade, C. acute MI, D. heart failure with preserved LVF.
Cardiac tamponade.
That's the right answer, because on ECG we can see very well see the electrical alternance. Next question for Dr. Akhil.
So a 32-year-old female presented with cough associated with eating since 4 months, fever since 15 days. This is the chest X-ray, this is the CT scan. And this is a bronchoscopic video. Next, please. So your options are, next please, what is the diagnosis? Time starts. Tracheoesophageal fistula, esophageal rupture, lung abscess, bronchoesophageal fistula.
Video, please. Video. Tracheoesophageal fistula.
Okay, incorrect. So why? Because this is, one of the superior segment what you see here.
Broncho.
So it's a bronchoesophageal. It's much way down. So trachea is, a big, since you are a pulmonologist, you would be knowing it's the ring.
That's why I asked for video.
Way down. So it's a bronchoesophageal fistula.
Yes.
Can you please show the X-ray once? I wanted to tell everyone something. One slide back. So what you see here is classical, right lower lobe superior segment pneumonia. This patient, whenever she was eating, she was having cough. And this subsequent recurrent pneumonia led to, abscess formation here. And when we were suspecting, but you can't see. In such cases, you put a rice tube and put methylene blue. And if that dye leaks into the bronchus, it means that there's a connection. And it was not leaking in the trachea, but somewhere way down. So it was a very unusual and peculiar case we had.
Round 3. Can we have the scores?
Okay, so Akhil Bansal at 10, Chetan at 15, Sandeep Bhargav at 15, Apul at 10, Manoj at 5, and Himani at 5.
So
According
is
to
it
score?
a tie?
No.
It's a tie between Dr. Chetan and Dr. Sandeep.
So it's a tie
It's
between
a tie between
Chetan Chaudhary, Dr. Sandeep Bhargav.
So can you please, rest of you, can you please, and we can just have the tiebreaker.
एक है ना एक है तो इसमें क्या करना है बजर ये तो एक ही क्वेश्चन है बजर
We will show the question and whoever raises the hand first. Or do you have that bell?
Bell or something like that.
Bell नहीं है कल वाला? So whoever raises the hand first would be, attempting the question. But if your answer is incorrect, then you lose the question. The other person wins.
And other will get the
Other
chance.
person
And,
will win automatically.
and let us complete the question, and then only raise the hands. And jury for this thing, who was the first one? Dr. Rao will take that. Next question. Final question for both of the contestants. A 65-year-old male presented with breathlessness to ER. EKG done. On 2D echo, patient have severe MR with normal LVF. After stabilization, patient is getting discharged. Which combination of medication is best for the patient apart from diuretics and AC inhibitor? Option A, amiodarone acetylene. Option B, bisoprolol and rivaroxaban. Option C, diltiazem and acetylene. Option D, amiodarone, rivaroxaban, and E, lanoxin and acetylene. First, you have to raise the hands. You people are taking your own time. Raise your hand and give the answer. Yeah. Sandeep.
Amiodarone and rivaroxaban.
That's not the right answer, not the best choice. Not the best choice. Chetan, it's your turn now.
B.
That's the right choice. Because beta blockers are supposed to be given their first choice, and rivaroxaban we are giving because they have a more compliance as compared to acetylene. For acetylene, you need to monitor your INR. For rivaroxaban, you don't have to. Second thing, the MR is not a valvular disease. We don't count it as a valvular AF. The valvular AF is MS. The quiz is over, and the winner is Dr. Sandeep, Dr. Chetan. The jury will tell.
I think it was very educational quiz and great participation by all the participants, and a big round of applause for everybody who was sitting here. And I was really impressed by some of the answers which were given by all the participants. So the second position goes to Dr. Sandeep, and the winner of the quiz who gets an iPad is Dr. Chetan. And the best answer you gave was 125. And that's, you should sometimes take a risk.
Can we have, all the people who participated in Start. Lunch has started, so please have lunch before you go. And it was really heartening. You know, everyone stayed till the quiz. I was not expecting. Thank you so much and hope to see you next year again for Heart Lung Update 2023. Acha, so we can get a picture also. Okay? ठीक है. हाँ. Sorry, there's a slight change of plan. We will just give the certificate and have a picture also that ways with you. Can you please? We will call each and every one of you. So, आप certificate के साथ. Mic देना mic.
Check.
Dr. Sandeep Bangarwa. Dr. Sandeep Bhargava. Dr. Vinayak Agrawal.
Dr. Rakesh. बढ़ाते जाओ. Dr. Abdul Qayyum Ansari. Dr. Rauf Ahmed. Dr. Babu. Dr. Narendra. Dr. Narendra Kumar Dara. Dr. Raghuveer Tunwal. Dr. Raghuveer Tunwal. Dr. Vivek Soni. Dr. Karamveer Singh. Dr. P.R. Gupta. Dr. Atul. Dr. Mohan Lal Gurjar. Dr. Tarun Prakash. Dr. Tarun Prakash Parashar. Dr. Vishnu Garg. Dr. M.S. Natani. Dr. S.M. Ahmad. Dr. Farhan Mansoori. Dr. Moin Ajmal. Dr. Moin Ajmal. Dr. Ram Saran Rundla. Dr. P.R. Gupta. Dr. Anula Sisodia. Dr. Bharat B. Sharma. Dr. Sharad. Dr. Sharad Tikawal. Dr. Muhammad Khalid. Dr. Danish Sheikh Qureshi. Dr. Himani Acharya. Dr. Rupal Nair. Himani Acharya. डॉक्टर स्वप्निल गुप्ता, डॉक्टर स्वप्निल गुप्ता, डॉक्टर हेमंत कुमार शर्मा, डॉक्टर विनोद चौधरी, डॉक्टर विजय, डॉक्टर अपूर्व माथुर, अपूर्व माथुर, डॉक्टर भाव्य माथुर, डॉक्टर चेतन चौधरी, डॉक्टर राहुल, डॉक्टर अनुज्ञा अग्रवाल, डॉक्टर राहुल, डॉक्टर अखिल बंसल, डॉक्टर नरेंद्र चौधरी, डॉक्टर राजेंद्र कुमार चंदेल, डॉक्टर जयपाल सिंह चाहर, डॉक्टर करण, डॉक्टर आलोक कुमार विजय, डॉक्टर मनोज कुमार माली, डॉक्टर भानु प्रताप सोलंकी, डॉक्टर संदीप बंगरवाल, डॉक्टर चेतन, डॉक्टर चेतन, अभी किसी किन लोगों को सर्टिफिकेट्स नहीं मिले हैं? ठीक है। नाम आपने इसमें लिखा है? कैप्स में लिखना।